To our AAACPN Masterclass for 2023. This is our first online foray, and so there may be a few teething problems, but bear with us. We have a number of sessions, both interactive and lectures. We ask, because there are so many participants, that if you have questions, please put them in the chat and they will get answered through the moderators. So now I'd like to hand over to Professor Sakamoto, who is the President of the Society, to give us some words of welcome, and then we will hand over to Dr. Chatterjee, who will be chairing this session.
Yeah, good morning, good afternoon, everybody. My name is Hiroaki Sakamoto. I'm a President of AAACPN. AAACPN is a face-to-face conference to deeply discuss various clinical aspect in the field of pediatric neurosurgery. It was held annually through 2019. The last AAACPN was held in Taiwan in 2019. However, due to COVID-19 pandemic, the AAACPN was postponed 3 times. This time, we are offering you the opportunity to attend the special AAACPN course using Zoom system named AAACPN Masterclass. Dr. Virginia Maxler, chair of the Educational Committee of AAACPN, in collaboration with Dr. Chandrasekhar Deopajali, has made a great effort to organize this special course. We deeply appreciate both of you. Before I turn over to Virginia, I'd like to announce that next Congress of AAACPN will be held in Yokohama, Japan this December. Thank you. Virginia, please.
I will now hand over to Dr. Chatterjee to chair the session.
Good morning, good afternoon, or good evening, depending on where you are in the world. This is a session on oncology. Before we get to oncology proper, we have to begin this meeting on a slightly somber note. And I'm going to share with you our small tribute to 2 members of the faculty of the AAACPN who have been faces in every single course of the AAACPN and who we miss most intensely today. They happen to be 2 very close friends, and this is the first of them, Professor Jim Goodrich. Jim, as you know, was a casualty of the COVID pandemic. Needless to say, Jim Goodrich was almost synonymous with the hands-on workshop that the AAACPN courses used to run. And this is a photograph taken during one of these workshops, where he demonstrated the different ways of operating on craniosynostosis. And of course, his lectures, particularly his lectures on skull reconstruction and calvarial reconstruction procedures, still echo in all our minds. I was given the arduous task of writing an obituary for this great man. And in fact, I began with the discussion we had during the Asia Australasian course in Bangalore in 2009, when Jim turned around to me and said, "Why is your Indian food so hot? Do you guys want us to starve?" And I remember in 2016, he came to my house and remembered his remark and said to me, "Your food is not hot at all. Is this because Bangalore is south of Kolkata and Kolkata is colder than Bangalore?" So in fact, Jim was an amazing person. In the last AAACPN course, he was awarded this certificate, the certificate of having completed 3 courses in the AAACPN was awarded to him for having been a faculty for such a long period of time. Little did the person handing over or the recipient realize that this was going to be the last certificate that Jim Goodrich was going to handle in the AAACPN. This is the last photograph of Jim I have attending an ISPN meeting, and this is the Education Committee meeting of the ISPN in Birmingham in the UK. Jim was an amazing man with amazing talents, and one who had the ability to always make his listeners listen to him. And I think his absence in this course will be sorely missed by us all. He always loved the excursions, and he took out this small miniature camera from his pocket as if he was handling a Hasselblad, and proceeded to take photographs. And this is a photograph of him accompanied by the present president of the ISPN. And this is in Warwick Castle in the United Kingdom. The other man, an equally close friend that I also lost in the last year, though not to COVID, was this man, Michel Serra, a man who made any meeting that he was present scintillating as much as he made it scientific in his presentations. Michel was, like Jim, a connoisseur of wine. And this is a photograph I have of him in my own home. Michel, of course, as you know, came from the other side of the Atlantic with views that were often different from those on Jim Goodrich's side. But he was an amazing thinker with an ability to come up with ideas that you would think, how the hell does he think like this? And I think this is his last visit to our hospital. He really liked coming to our hospital and visited the Park Clinic in Kolkata as many as 5 times. This is his last visit, and in fact, his last lecture, which I have a photograph of for posterity, and it's shot in 2018. This is the last photograph of Michel attending a course. This is in South America and Brazil, during the course in Brazil. And he was looking tired and looking very worn out when he came to this course. But when I said to him, "You don't look well," he said, "Change your glasses." His laptop was synonymous with his contribution to pediatric neurosurgery. And even if he appeared to be asleep in front of the laptop, and I'm sure Michel will forgive me for this photograph, he would suddenly wake up and have the amazing ability to ask a question which was so pertinent that you wouldn't have thought of it even if you had heard the lecture wide awake. The last photograph of Michel in Kolkata, this is during the meeting of the Indian Society of Pediatric Neurosurgery that we hosted a few weeks before this horrendous pandemic descended on this globe. And as you can see, there are a number of friends from the AAACPN in that course. And this was in an evening where we were relaxing after the meeting. This, in fact, is a photograph taken when he came to the AAACPN course in Kolkata in 2016. And both of us looked a lot younger. But Michel, in that course also, had the audience in absolute wondrous amazement at the various things that he talked about. He was always willing to learn. This was in my roof garden when a South African neurosurgeon, you can guess who, taught him how to hold the cricket bat for the first time. And he told me, "Take a photograph because this is the first time I'm holding a cricket bat. It may also," he said, "be the last time I hold one." And it probably was. So these are two stalwarts of the AAACPN that we have lost since the time of the last meeting. And I thought I'd share this rather unique photograph that we took in Calcutta during the AAACPN course, because it was during this course that I had the good fortune of sharing a position in that photograph panel with two of these very, very great men whose loss we really, really feel intensely as we begin this course today. Thank you very much for your attention. Right. I think all of us will agree that these two have made amazing contributions to our courses in the last decade. Time to get to oncology now. And it gives me great pleasure to introduce to you the man who's actually worked a lot to make this course possible, and somebody who really doesn't need a formal introduction to this audience, Professor Chandrasekhar Devpujari from Mumbai, India. And Shekhar is going to talk to us about his favorite topic, craniopharyngioma. Shekhar, you need to unmute yourself.
Thanks, Sandeep, Virginia, Professor Sakamoto, for this opportunity. And it's really a pleasure to get back together after a long time. I welcome Professor Van Tu as well as Meng Fai, who have now joined us. And I'll share my screen without wasting too much time, which has been allotted to me. So the basic concept of this course, as Virginia and we all discussed, is actually to discuss some kind of a case which would allow us to talk a few things about the topic which we are discussing. And I have chosen a particular variety of craniopharyngioma for the next few minutes to discuss with you. And during the case discussion, we can probably talk some more about this topic if I get the opportunity to share one or two cases. So I think I've had the opportunity to head this organization before Professor Sakamoto. I'm really thankful to all the members. I think we all know that craniopharyngiomas in children are different than craniopharyngiomas in adults. And I think with the molecular biology difference now being very clear, they certainly seem to be two different varieties. Pathologically, we have seen that adamantinomatous type with cyst formation is more common in children than adults, and the beta-catenin gene is seen almost in 70% of children. Calcification is more commonly seen, and about presence of hydrocephalus, I think it is much more common in children compared to adults. The main areas of controversy in craniopharyngioma are the extent of surgical resection. You can always have debates of radical versus conservative resection. The other equally heated debate is about the surgical approach and use of adjuvant therapy. I think everybody acknowledges, but when to apply and what to apply is again a matter of debate. I think all this cannot be considered in the next few minutes. So let us start with this case. This is an 8-year-old boy who came with raised intracranial pressure, typical story of headaches going on for about 2 months, increased recently with projectile vomiting. And there has not been any definite side on which he had a visual problem, but he complained of blurring all right. And these were his MRI pictures on coronal and sagittal images. And what it brings us to understand is how are we going to treat this tumor. So surgical approach is mainly dictated by direction of the tumor growth and familiarity of the surgeon with a particular surgical approach. Choice of surgical approach has a strong influence on the outcome from the papers if you read who favor a particular approach. And currently, really, there is no best surgical approach for a large suprasellar craniopharyngioma. though endoscopy has made a great contribution to this. So when we really talk about choice of surgical approach, we differentiate between sellar tumors, which are naturally best treated by the transnasal route, and the intraventricular tumors, which are treated by the transcranial intraventricular route, and suprasellar tumors, we leave it during the case discussion maybe. So this patient had a typical intraventricular craniopharyngioma. The normal criteria which used for this are you should have a normal sella, you should have a patent suprasellar cistern, the pituitary is separately seen, and the floor of the third ventricle is intact and in fact is downward, there is downward bowing. So I actually used the middle frontal gyrus approach, entered through the foramen of Monroe, as you can see very nicely. This case is operated about 11 years ago. And at that time, I did not consider it purely endoscopic surgery. So this is an endoscope assisted surgery. We decompress the cyst and we have started taking this tumor out. I'm not going to show the whole video, but you can see that as the cyst gets more decompressed, it is separating from the third ventricular floor. We are going further down and some remnant is remaining at the top now. And even that is coming out, and you can see actually at the end of the procedure, you can see the intact third ventricular floor. So this is the intact third ventricular floor. The last bit of the cyst wall is coming out, and that's where you see that the whole lesion is out. So these are the various steps, and you can see that the whole tumor is out along with the calcified wall. And this is the post-operative CT scan, which shows that there's some droplets of blood, but otherwise the whole lesion is come out. And this is about, as I said, 8 or 9 years ago, and this boy has not had further radiotherapy, and he has not developed any recurrence when his yearly MRI scans are being done. So this particular variety of craniopharyngioma is not very common. And this retrospective study, which talks about 104 well-described intraventricular tumors from literature over a period of years, divides them into two kinds of intraventricular craniopharyngioma. A strict intraventricular craniopharyngioma, where on the surgery you have a proved third ventricular, normal third ventricle floor. In fact, when you say that, you have not gone through that into the suprasellar cistern, and more commonly you get what he calls is not so restrict or non-restrictly intraventricular craniopharyngiomas. And these two different topographies are important because in a purely intraventricular third ventricular craniopharyngioma, you have a much easier decision to make the approach, as well as you have a much better outcome. We actually wrote about our experience of about 24 cases with another colleague, cases between us. And what are predominant points are that you must first satisfy the criteria which we just discussed about the bowing and the patent suprasellar cistern. If you look at the clinical signs and symptoms, you find that the visual signs and symptoms are comparatively rarer, and certainly you do not get so well-formed field defects as you get in a suprasellar craniopharyngioma. And with advent of endoscope, it became a procedure which could be done we try to perform a small craniotomy so that you can pull the whole cyst out towards the end of the procedure. So this remains a endoscope assisted procedure. You break the cyst, you decompress the lesion, and once you have come to a stage where you can easily see it, then you can gradually take this out through the small craniotomy which you have created, like in this patient. Again, this is operated about 6 years ago. And this is a more recent case with better endoscopic visualization. It has become much more easier. And addition of what is called endoscopic CUSA has made it easier even to remove the solid portions. And one of the other colleague of mine, who's one of the authors of this paper, he also performs a third ventriculostomy after that, when the third ventricular floor is intact, so that the external ventricular drainage need not be kept longer. And this is our experience of how we have treated this with open or purely endoscopic surgery in more recent times. And we managed a complete resection in about 40% of cases. Post-operative complications are fortunately not so common. The most of them are related either to hydrocephalus or mental deterioration, and most of the recurrences are seen in first 3 years. So close follow-up for the first 3 years is very, very important. Thanks for a patient listening.
Thank you, Shekhar, for that very good and succinct talk. Do we have any questions? Because I can't see any in the chat box. Is there any of the people who are here who wish to ask Shekhar a question? Please feel free to do so.
Just check the chat box.
Yeah, the chat box doesn't have a question. That's why.
Chat box has only tributes to the two senior guys who have left us. So if there are no other questions, we can probably have them during the case discussion. If Virginia, you have some time during that.
Yeah, I mean, is there anybody? I can ask a question then, Shekhar, to you.
Yeah, please.
When you
I think the faculty can make comments or questions, whichever.
When you see a child with a craniopharyngioma, say a very large craniopharyngioma, because you're a pretty wizard with endoscope. When do you ever now decide that you don't want to do it endoscopically and you want to do a craniotomy for it? What's the main criteria that you use? Has age of the child got something to do with it? Has pneumatization of the sphenoid sinus got something to do with it? Or has the size of the tumor indeed, the paper from Paris about involvement of the hypothalamus, is that something you think is a very useful way of deciding?
I'm still collecting data. I'll take the question backwards. Importance of hypothalamic involvement. I think if the patient has clinical hypothalamic involvement, it is certainly extremely important. I think the Puget criteria for hypothalamic involvement on imaging, I have seen that they have been frequently fallacious, because once you drain the cyst, you can start seeing the hypothalamus in many of these patients. And drainage of the cyst is one of the early or the first line of action in many of our patients, where we need to wait for a detailed endocrinological and other workup to go for a definitive surgery. So I offer that as the first treatment to many of the patients who have large cysts. In terms of age, yes, it is extremely important. If I get a child below the age of 3 years, it is difficult to do it endoscopic transsphenoidally. Below 3 years, I would prefer only drainage of cyst and use of alpha interferon currently. Till they become more than 3 years, then we decide if we are going for surgery or going for radiation. In terms of what are the general criteria for doing a craniotomy, I think the most important criteria is lateral extension. If the tumor has extended on either side into the temporal foci, or if you think it is engulfing some vessels, then I would not like to try endoscopic transsphenoidal approach. Endoscopic intraventricular approach I have used in quite a few patients who present mainly with hydrocephalus. Rather than putting a EVD, draining the cyst relieves them, and then you can decide if you are going to radically excise or subject them to complementary therapies.
Fantastic. Thank you. I think that should be very useful to the trainees who are here.
Dr. Ra has a question.
Yeah, Mr. Chaudhary, Dr. Chaudhary.
Yeah, go on. Please.
Oh, yeah. But Professor Diopajari, I have good the hearing from you, and then you are a master of the pediatric tumors, and I have a question about in the incomplete resection of your cases. So do you think the radiation therapy, how much is effective to prevent recurrence? You proceed with the radiation therapy in case of incomplete resections?
Yes. So currently, patients going immediately after the first surgery for radiotherapy are children above the age of 5 years, where I think the rest of the tumor cannot be removed. Most other patients where I think I have done a reasonable excision, and especially below the age of 5 years, I would wait. Most of the times, the radiotherapy is advised after the second surgery, if at all it is required, or if there is a definite evidence of growth in the residual tumor. How effective it is? We actually have now even proton beam available where the tumors disappear pretty quickly. Overall results probably are the same as we heard in Singapore with LINAC and proton. But I think the rapidity of tumor resolution is much better seen with proton beam, which recently 3 or 4 of my patients have undergone.
Thank you.
Yang Shin, you're okay?
Yeah, thank you.
Great.
Yeah.
Any other questions? Fantastic. If not, thank you, Shekhar, and we'll go on to the next speaker, which is welcome to the president of the International Society of Pediatric Neurosurgery, still recovering from a fantastic conference that he's hosted just a month ago. Wan Tiew, welcome to the program, and you're going to talk to us about pineal tumors.
Okay, thank you very much. Sorry, Sandeep. Yeah. Okay. Thanks a lot. Okay, so I'm gonna follow what Virginia has wanted us to do, which is to talk about 5 points. So, what are 5 lessons on pineal tumors that I've learned? Okay, starting, was the rare tumors, but they all come from different cell origins, and being in Asia, Southeast Asia, East Asia, or germ cell tumors actually are the most common. So actually not so rare. And I think then if you are suspecting germ cell tumors, you use serum or CSF markers to make a diagnosis. So I think as one of our old teachers used to say, Christian Serros, markers. Then of course, diagnosis of pineal germ cell tumors using MRI and tumor markers only may not be enough. There may be a need for histology. Then 4th point, if there's a need for CS diversion, then preferences for endoscopic third vectoscopy, since there is some opportunity for endoscopic biopsy, and then open surgery is needed for second look surgery for germ cell tumors or tumors unresponsive to chemotherapy, radiotherapy, or even the benign tumor. So let's look at the points. I think all of us know tumors arise from the cells of the pineal gland, germ cells or structures around regions. So you have pineal sites, and you have germ cells, and you have others. And then even in the germ cell region, you can see there are actually different types. So you have the germinomas, non-germinated germ cell tumors, teratomas, embryonic carcinoma, yolk sac tumors, chorocarcinomas. Then the pineal parenchymomas are the pineocytomas, pineoblastomas, and then pineal parenchymal tumors of intermediate determination. Then you get gliomas, and then of course even meningiomas, ependiomas, neuronal tumors like ATRT and so forth. Okay, so they are rare, but being aware in the world you are, so if it is Asia, right, it is actually not that uncommon. Okay, so right. Then the other thing when you talk about germ cell tumors, I think a very important part is to actually know that there's such a thing called a growing germ cell tumor. Basically, what you have is a germ cell tumor. Maybe it looks like a germinoma. You may biopsy it. After chemotherapy, radiotherapy, radiotherapy, the tumor then starts to shrink. But then after it stops, and then it starts to grow. And so that tumor in reality is what we call a mixed germ cell tumor. There's actually a germinoma, or it may be a non-germinated germ cell tumor. But there is also a teratoma, which is benign, so it's not affected by the chemotherapy. So with the chemotherapy, radiotherapy, the malignant component has been controlled, but the benign teratoma continues to grow, increasing in size. The second point is if you're suspecting germ cell tumors, of course, markers, serum or CSF tumor markers to make diagnosis is important. It's part of classic teaching. So tumor markers, right? So you can be present in blood or CSF. And then that's because germ cell tumors can express embryonal markers. The 2 common ones that we look at are beta HCG, alpha beta protein, and that's why they're called secretory germ cell tumors. But there are also other things, markers that are used in some places where, say, PLAP is available. So analysis of the serum and CSF for presence of tumor markers will guide further measurement. And of course, the presence of abnormal level tumor markers, right, especially if you see a pineal tumor on imaging indicates a germ cell tumor, although it may not be able to be you may not be able to very specifically say what is the histological type. Right? So these are some of the levels that you can see in this type of markers. And then this is a case, although this is not a pineal tumor, but you see this is a 13-year-old boy with left-sided weakness. The MI findings is shown as well. So it's a lesion in the basal ganglia, but his serum alpha-fetoprotein is raised. So this patient is thought to be a non-germinated germ cell tumor. So classic teaching is there's no need for biopsy. You start chemotherapy and radiotherapy, and indeed, this child is responding to the thing. So after 4 courses, you can see there's a bit of weakness left, but the tumor is controlled. But the thing is that especially when you look at the Japanese society and probably even Koreans are saying that the tumor markers is not enough. You will need to have histology. And so this is really a major difference in the diagnostics between, what is practiced in countries like Japan versus Europe and North America, right? Because histopathology diagnosis there is the gold standard. And so you can see how they actually look at, the way they look at in terms of diagnosis and treatment. Right? So a little bit different from what is classically taught in Europe and in North America. All right. So basically, germinomas and tenomas with elevated tumor markers can be heterogeneous diagnosed and treated using different protocols. And really, so the question is it necessary to have histological diagnosis? The Japanese will say yes, right? Because they have evidence that MRI is not diagnostic of germ cell tumors. Not all bifocal tumors are germinomas. They can be non-germinal germ cell tumors. All right, and even in some of these cases, all right, marker negative NG, non-germinal germ cell tumors, marker positive germinomas, and non-germinal germ cell tumors can be encountered. So basically, you should not consider diagnosis basically on tumor markers as what or imaging or clinical findings, because they can be limitations. So if there's a need for CSF diversion, the preference therefore is 0.3 for endoscopic biopsy, okay? Because the tumor is in the pineal gland, they obstruct posterior wall of the ventricle, and then they obstruct the aqueduct sylvus, and then resulting in acute hydrocephalus, right? And it seems that a 2 centimeter pineal tumor can cause obstructive hydrocephalus. So ETV is favorable over shunting because there's a risk of tumor dissemination by a shunt, and then of course long life complication. And the other thing, of course, is when you do a third ventrectomy, you can also biopsy the tumor. And also you can see metastatic deposits, especially for germinomas, and this can help in the staging of the disease and can affect the treatment that's given. So I think all of us know, right, it's a small burr hole, just about 2 centimeters, and maybe from the midline, 1 centimeter in front, and then we just do, and then while you're treating, you can attempt a biopsy. But there may be possibility that you may not be able to see them. And if you try to actually, push your endoscope, you may actually then cause damage to the fornix. Right? So in the cases where you cannot see, you do have a flexible endoscope. You can put in a flexible endoscope to take a biopsy, or you can do a separate frontal burr hole for your endoscopic biopsy. But you have to use image guidance to make sure that you get to the foramen Monroe, and from there you can see. And I think you can see quite clearly once you get actually through the foramen Monroe here, right, in the endoscope, and you can see the pineal area, and then here you can see the tumor coming out, and you can just take a biopsy using the endoscope. Okay. Even here, you see there's a little bit of injury to the foramen Monroe, but not very much. Okay, so this is germinoma. Okay, so then what about the diagnostic yield? I think it's very good. Basically, this is a systemic review, and their conclusion is that it's a very good diagnostic tool and use with a low complication rate, and the yields are actually around 88%. Okay, or sorry, 82% in this case. And it's just as good, if not better, than endoscopic biopsy. Right, so finally, open surgery may be needed. So if you find the tumors, you can see there are several different approaches. Either you can do the infratentorial supracerebral approach or the occipitotransdental approach. So you but you realize that actually there are complications related to sitting position, complications related to this also transplantorial approach in terms of visual cortex injury, the vascular injuries, because there are lots of big veins there. You get post-operative hemorrhage, you get brainstem injury, or extraocular movement dysfunction, ataxia, and so forth. And it's also not without risk. The mortality rate can be up to 4-5%, and morbidity even a bit higher, right? So, and then you always get asked, which is the better approach, right? Should you use an intratentorial, or so you use a occipital subtentorial? And realistically, they're saying that, the tumors is much higher up. Maybe the occipital, it's an intratentorial supravellar approach is better. If the tumor is lower, maybe the occipital subtentorial approach is better. But in reality, these are very not common operations that you do. And in my opinion, if you would learn to do one, you just stick to one, because you probably can get most of the tumors out. Okay, and of course, next AAACPN meeting is in Chile, but we hope to see you also in Yokohama at the end of this year. Thank you very much.
Thank you, Wan Chiu. Do we have questions for Wan Chiu before we let him run away?
There are no questions in the chat. So can I just remind people to put them in the chat, and we'll be able to have them answered.
Thanks, Virginia. Hope I followed your advice closely.
You did. Wan Chiu, I just wanted one thing, whenever we look at tumors, pediatric tumors from this part of the world going further east and south, pineal tumors seem to predominate. But when you look at the similar age group further west from where we are, the incidence seems to fall a lot. Is that genetic or racial, or what do you think is the cause of that?
Well, I think if you just look at around the world, I think germ cell tumors, whether they're in the pineal region, suprasellar region, even in the basal gland, I think it's much more common, as you can see in the figures shown, in the East Asian. So you're talking about, say, Chinese, Japanese, Korean, but also in Southeast Asia, like our Malay population. So again, also Indonesia, Philippines, they're probably more common. I think like when I was working in Australia, the pineal tumor, germ cell tumor that I saw was actually Chinese, Vietnamese, So yeah. I think it is racial to a certain extent. Exactly what, I'm not sure. Right? I'm sure there'll be people, doing studies on that. Maybe some of our Japanese colleagues can actually mention something.
Yeah, I was just wondering, have you got any genetic studies done in Singapore on this?
Sandeep.
Yeah, VP.
No.
We're getting Professor VP Singh. VP?
No, carry on. My question. Right. Wonderful presentation, thank you. My question was, should we do a serum and a CSF diversion? Am I audible?
I think basically you do serum, but I mean, if these patients have hydrocephalus, they will need CSF diversion. So the point is that if they need CSF diversion, then endoscopic third ventilostomy is actually a very, very good procedure to do. And then while you're at it, you might as well take a biopsy. That's what we're saying. Because I think that I think if you get biopsy, it's actually much better than if you don't have a biopsy and just working on serum. Because I think there are some studies, there are some examples that sometimes this classic thing of alpha-fetoprotein beta HCG means it has to be a germ cell tumor, or secretory germ cell tumor. But there are some suggestions that not, especially in the group of the teratomas. It's not only just benign teratomas, you get actually malignant or immature teratomas, they also will secrete. And they are much harder to treat with chemotherapy, radiotherapy. They may still need to have surgery.
No, my question was, if you do not need a CSF diversion in a patient, even of course do the serum markers, should we go for CSF markers also in addition to a number puncture?
Yes, I think that definitely will help. I'm sure if you're going to give chemotherapy or radiotherapy, your oncologist will probably ask for that. And normally in our practice, they will do it.
Great, thank you. Any other questions to Wentu?
Yes, I have a question for Professor Xiao. So for the growing tumor syndrome, usually we will give these patient chemotherapy first. And I have a patient recently with Yosak tumor, and we take a biopsy and start the chemotherapy, and the tumor marker, the alpha protein, decrease significantly to normal range, but the tumor is still enlarging. So then the oncologist came to me, so say, should we start surgery or should we do the radiotherapy first, then consider surgery later? What's your opinion?
Well, it depends on your practice, but I think if you have radiotherapy, I think it's okay to give radiotherapy first because you actually have a mixed germ cell tumor. You need to complete treatment of the yolk sac tumor because chemotherapy is not sufficient for that, right? So I guess it doesn't matter which is what. If you feel that you need to get the surgery done first, go ahead. I'm in the case discussion. I will show a case quite similar to that. But I think it's something that you can decide with your therapy. I mean, I know that, you see, the other thing is once you actually have removed the tumor, because the chemotherapy is useful, but it's not sufficient for all these non-germinal stem cell tumors, even for germinomas. You need both. And then so you need to consider the protocol because once you do surgery, you might actually then miss the timing. Because everything is about protocol. So if you miss the timing because the patient needs to recover, then the therapy might be too late. So sometimes they may want to have the chemotherapy and radiotherapy completed before you go and take out the teratoma.
Okay, thank you. Because I'm going to talk about ependymoma. So for other kind of tumor, it seems that radiotherapy should be reserved as the last resort. So surgery should be done to remove as much tumor as possible, but maybe it's different for germ cell tumor.
Yeah, ependymomas need radiotherapy, so I think it's a separate issue from germ cell tumors. Right, because teratomas are benign. Once you clear the teratoma, that's it, finished. Right?
Yeah. Okay. Thank you.
Great. So Shi-Hung, stay online because you're the next speaker, so you can remain unmuted. And thank you, Wentu. And I have great pleasure in welcoming to this course Shi-Hung Yang, who is a pediatric neurosurgeon from the University Hospital in Taipei, in Taiwan. And he's going to talk to us about ependymomas. I'm also going to take this opportunity to thank Virginia for being allowed to chair this very first session of the course. And I'm going to hand over the chairmanship of the rest of this session to my boss in the education committee, the one and only Virginia Wexner. So Virginia, if you'd kindly take over because I unfortunately have to go to the operating room.
Thank you, Sam.
All yours, Shi-Hung.
Bye-bye.
Okay, thank you. So today I'm going to talk about ependymoma. Sorry, this is the wrong slide. Okay. I'm Shi-Hung Yang from Taiwan. I work in the National Taiwan University Children's Hospital in Taipei City. I was also the president of Taiwan Society for Pediatric Neurosurgery. And currently, I am the Secretary General of the Taiwan Pediatric Brain Tumor Consortium. So this is today's outline. So we know ependymoma derives from the ependymal cell in the ventricular wall and central canal. It commonly arises from the supratentorial posterior fossa and spinal compartments. In children, the most common location is posterior fossa. And the most common pathology is grade 2 ependymoma. Besides anatomical location, histopathology, nowadays we will use molecular biomarkers to classify ependymoma into 9 or even more subgroups. And the standard treatment of ependymoma is surgery and radiation therapy. Chemotherapy plays a minor role in the management. Maximal safe resection followed by radiation therapy will provide best outcome for the patient. So, case 1, supratentorial ependymoma. This is a 15-year-old male presented with progressive left leg weakness and myoclonus for weeks. MRI show a right frontal parietal tumor with both solid and cystic component, measured 6 centimeter. So we did a craniotomy for nearly total tumor resection. The post-operative MRI showed a small residual tumor less than 5 millimeter. Pathology revealed anaplastic ependymoma WHO grade 3 ZFTA fusion positive. So, which is the most common supratentorial ependymoma with poor prognosis. The other molecular subgroup of supratentorial ependymoma is the YAP1 fusion tumor, and this has better prognosis. And besides the prognostic implication, there might be therapeutic implication. For example, should we avoid post-operative radiation therapy for good outcome tumors like YAP or PFB? And should we give target therapy for poor outcome tumor like the ZFTA or PFA tumor? But this need to be seen in the future. So for the treatment, for intracranial ependymoma with no or minimal residual disease after radiation therapy, the standard treatment is surgery followed by radiation therapy. So for this patient, we will give radiation therapy after surgery, since the postoperative CSF study and the MRI shows no CSF seeding in the spinal compartment. Case 2, posterior fossa ependymoma. This is a 5-year-old girl with abdominal pain and vomiting for weeks. The CT scan show a posterior fossa tumor with calcification, and MRI shows left foramen lucica extension. We did a suboccipital transvermian tumor resection and the external ventricular drainage for the hydrocephalus. The pathology showed an anaplastic ependymoma, posterior fossa type A, which is the most common posterior fossa ependymoma, with also a poor outcome. The postoperative workup showed some residual tumor, 1.5 centimeter in the foramen lucica, and spine MRI and CFS cytology were both negative. So what to do next? So according to the guideline, for intracranial ependymoma with residual disease after surgery, we should consider second look surgery when feasible, followed by radiation therapy. As this study shows, for patients with residual tumor, the outcome is worse than patients with no residual tumor or minimal residual tumor, either after primary resection or second look surgery. So for this girl, because we did a subtotal resection, we gave her 2 courses of chemotherapy, followed by a second look surgery to achieve a near total resection of the tumor with some residual tumor on the brainstem surface. And we then give her radiation therapy. And she is neurologically intact with no recurrent tumor 2 years after therapy. Case 3, spinal ependymoma. This 9-year-old boy with back pain and progressive paraparesis for months. MRI shows 2 spinal tumor at thoracolumbar and lumbar sacral junctions. We did an operation to remove both tumors totally. Pathology revealed a myxopapillary ependymoma. And then we gave him focal radiation therapy, and he is disease-free and neurologically intact 4 years after therapy. So for myxopapillary ependymoma, the WHO classification in 2021 changed the grade from 1 to grade 2, as some recent study revealed the outcome of spinal myxopapillary ependymoma is similar to grade 2 spinal ependymoma. So some physicians will consider give radiation therapy after total tumor resection, as our case. And our case show a special presentation of double tumors in the spine, which has been reported in the literature also. And some receive total resection only, and some receive total resection followed by radiation therapy. And both has good outcome. We all have good outcome. And the last case is recurrent ependymoma. And this is a 6-year-old boy. And he had intracranial anaplastic ependymoma at 4 years old. He received total tumor resection, and the CSF cytology and spine MRI were both negative. So with focal radiation therapy to the posterior fossa was given. However, 2 years later, he had urinary incontinence, and spine MRI shows recurrent tumor in the thoracolumbar spine. So total tumor excision was done, followed by local radiotherapy to the spine. And as we know, recurrent ependymoma mostly recur locally, but some may develop in the distant compartment. So for our patient, he received only focal radiation therapy to the posterior fossa. So maybe we should give him prophylactic cranial spinal irradiation, so he might have the late distant recurrence, like the case we will perform for the medulloblastoma. But some study reveal there is no additional benefit of cranial spinal irradiation for ependymoma patient with M0 state. That means no dissemination in the spinal compartment. So only when there is spinal seeding at initial presentation, then we will give the ependymoma patient with cranial spinal irradiation after surgery. But if there is no spinal seeding, then focal radiotherapy is recommended. And how about early detection? In this case, we use the EVD to do CSF cytology, but the CSF in the ventricle may not reflect the real situation in the spinal compartment. So some physicians will recommend lumbar puncture, additional lumbar puncture to study the CSF to increase the diagnostic yield of spinal seeding. And also, maybe we should consider routine follow-up after surgery with brain and whole spine MRI every time to allow us to early detect tumor recurrence distally. But there is no consensus. So in conclusion, the standard treatment for ependymoma is maximal safe surgical resection followed by radiotherapy. And when feasible, second look surgery should be performed. And molecular classification is incorporated in the WHO 2021 classification for ependymoma now. spinal myxopapillary ependymoma is a WHO grade 2 tumor now, and recurrent ependymoma should be managed with the same principle of newly diagnosed ependymoma. Thank you and Happy New Year to everyone.
Thank you very much, Shihung. There is no questions, so I'm trying to encourage the participants to post questions in the chat so that we can then answer them. Does anyone have any questions for Shihung? Maybe I could ask a question, if I may.
Sure.
We also have cases where we've done the primary surgery, but by nature is incomplete, typically in a very young child, so in our under 2 age group, and very large tumours. And there's always a discussion about the role of chemotherapy in these children and aid to delay radiotherapy, but also its effectiveness in ependymoma. Do you feel that it has a specific role in some of these younger children? Do you feel it changes your next surgery, for example?
Yes, we know. For the young patient, radiotherapy may not be very appropriate. So generally speaking, I mentioned chemotherapy is not so effective, but for the young patient with no option for radiation therapy, more intense chemotherapy or even the with autologous stem cell rescue may be applied. And I think there are some reports in the literature that this therapy can control the tumor and to wait until the patient grows older to allow radiation therapy.
We have a question from the chat from Asma Afifi. What is the waiting time or duration to wait after surgery and before the first radiotherapy? How long do you wait between them?
Usually we will wait for 2 to 6 weeks to allow the good wound healing and then do the radiation therapy. I don't know if any other faculty will have different approach.
Professor Yang, I have a question.
Yes.
Yeah, about in the recurrent ependymoma. So as you know, very good lectures, and I really appreciate. And then in case of a recurrent ependymoma, is probably local, right?
Yes, most of the time. Yes,
actually. And then after radiation therapy. So what is your options after resection of the tumor? I mean, recurrent tumors. As the last summary, you're going to do the radiation, or what is your adjuvant therapy after second resection of recurrent tumors?
Yes, well, we will try to apply like cyber knife or gamma knife radiosurgery to avoid radiation injury, because this is more focused therapy to the tumor bed. But usually it can only control the tumor for a while. If we cannot achieve total resection for recurrent ependymoma, usually it will come back. It's a very difficult condition to treat.
Right. Yeah, I agree with your comment. Yeah, it's not easy, but somehow the radiosurgery somehow the temporarily control the tumor, but eventually most of them recur back, right? Thank you.
Yes, thank you.
Thank you, Shihung. So I'd like to invite Dr. Takayuki Inagaki for the next speaker.
Hello.
Welcome, Taka.
Thank you very much, Virginia. I sent my pre-recorded PowerPoint yesterday. May I use that one? Medulloblastoma is the most common malignant pediatric tumor in the CNS. Symptoms are often progressive over weeks to months. Symptoms related to hydrocephalus are often present because of the tumor location. Cerebellar ataxia may also be observed. Although some syndromic medulloblastoma are reported, majority of medulloblastoma occur as sporadic case. Preoperative diagnosis are made by radiological exam. With CT, medulloblastoma often appear as a mass arising from the vermis and occupy the fourth ventricle. They are usually hyperdense, and cyst formation is common. Calcification is also seen. Tumor is hypointense on T1, iso to hyperintense on T2 or FLAIR. Tumor is also strongly enhanced with contrast material. Elevated choline and decreased NAA on MRS is reported. Patients with medulloblastoma most commonly have symptoms related to increased ICP. Usually, those symptoms precede presentation around 2 months. Younger patients tend to have a problem of behavior. On the other hand, older patients complain headache. Vomiting without nausea is more common in the morning. Patient may develop double vision due to sixth nerve palsy. Visual disturbance is caused by the papilloedema. In advanced disease, head tilt and neck stiffness may be observed. Surgical management is very important for neurosurgeons. First, how to manage hydrocephalus. As you know, there are 3 types of the treatment for hydrocephalus. First is endoscopic management, second is shunt placement, and third is EVD placement. Tumor removal is also very important. We should remove tumor as possible we could. If tumor remain after first surgery, we should perform second surgery. And it's better not take all tumor out if there is some strong adherence to the floor of the fourth ventricle to avoid severe complication. Now it's classified into 4 types based upon molecular study. Wind type is considered as a very good prognosis group. On the other hand, the other 3 may behave differently. Other than the molecular study, if young age at diagnosis, incomplete surgical resection, and presence of CSF metastasis at the time of diagnosis, those are considered as a poor prognosis group. Several regimen was published for standard risk group and also high risk group. After treatment, we should follow the patient both spinal and brain MRI every few months. The first case I will show you is 9-year-old boy. His complaint is nausea and vomiting. Because his symptoms improved with infusion, initially it was not thought to be a brain tumor. 1.5 months later, he was referred to our institute. Because he started to lose his body weight, we were asked to examine. Neurological examination revealed he was not able to gaze to the left, and also he was difficult to stand. MRI showed low intensity mass on T1 and high intensity mass on T2 inside the fourth ventricle. With contrast, tumor was strongly enhanced, and on CT there is small calcification. As I mentioned earlier, we have to treat both hydrocephalus and the tumor itself. My personal choice is when OR is available for tumor removal, I do insert EVD at the setting to the tumor removal. On the other hand, OR is not available for tumor removal. Usually, I do perform ETV first, then wait for tumor removal. MRI on slide is after surgery. As you can see, there is a remnant of the tumor around the fourth ventricle. I prefer not remove all the tumors because there is a strong adhere of the tumor to the floor of the fourth ventricle in this case. After surgery, he complained double vision, facial palsy, and cerebellar ataxia. Even I left some tumor on the floor of the fourth ventricle. After discussion with oncologist and radiotherapist, we treated him with the regimen published by St. Jude. This MRI is the one taken after adjuvant therapy. There is some enhanced region on the fourth floor area, so that I needed to remove a tumor again. But fortunately, there is no tumor cells but gliosis. Second case I will show you is 9-year-old girl. She has a long history of headache. Actually, she visited a neurosurgical clinic the other day, and the MRI shown is the one taken there. Only one slice, but there is a tumor, but it's missed. These are the MRI images taken at our institute. Tumor has a large cyst. As I mentioned, we could not do the tumor removal. We did ETV first, then wait for tumor removal. MRI on this slide is taken after surgery. Gross total removal was performed in this case. Chemotherapy and radiation therapy was added. However, 2 years later, she told mother she started to fall easily. We examined her but find no cerebral sign. On the other hand, she had a weakness in lower extremities. We find brain tumor and multiple spinal metastasis. Because we could not remove all spinal metastasis, our oncologist treated her with high-dose chemotherapy. Tumor was controlled. On the other hand, because of high-dose chemo, she has a side effect, as you can see on this MRI. Making a differential diagnosis also very important. The case on this slide is a boy with ependymoma. This is another case. Young girl came to us with difficulty of walking. On T1 and the flare, there is some fluid inside the tumor. This was enhanced but not so strong as typical medulloblastoma. This case turned out to be a ATRT. I showed you two cases today. First case is wind type and good prognosis. Second case is group 4 with P53 mutation. Her course was not so good compared to the first case. We need to treat medulloblastoma patient with oncologist and radiation therapist. Thank you very much for your attention.
Thank you, Tucker. Do we have any questions for Tucker? Maybe I could ask one, Tucker. It can be, more a comment, I guess, than a question. It can be incredibly challenging to get that plane on the floor to know when to stop. That is a real challenge. I have a child recently where I had an excellent removal, and we were right on the floor, but even that was too much. But it can be very, very difficult to know when to stop. That's certainly my experience. So I totally agree with you.
Yeah. Actually, when I was very young, my senior tried to remove all the tumor. And I had actually a very hard time to taking care of those patients. Some patients even need tracheostomy. So it's sometimes very miserable. So I try to leave tumor there. Thank you for your comment.
Can I ask a question?
Sure.
Absolutely.
So, in your policy for these patients, how frequently are you performing ETV before surgery?
Actually, it depends on the schedule in the OR and the answer from the anesthesiologist. If they allow us to remove the tumor, I do not do ETV. However, they ask me to wait maybe 3 days or 4 days. I do ETV. It's very simple. It's not my personal, only my personal choice. It depends on the schedule.
But regularly you are going straight for the tumor.
If possible, I prefer to do that.
Thank you.
Thanks.
We have a question from Mona. If there's a pseudomeningocele post-meduloblastoma surgery, what do you do? How do you treat that? How do you prevent it?
I'm not sure because I'm not severe a problem in pseudomeningocele after surgery. So that I don't know the answer. What I'm doing is doing close dura tightly as possible. Maybe that's the key, I guess. And I do not try to use sensitive any materials in children, like Gore-Tex.
Tucker, I have a question.
Yeah.
So do you think about the proton radiation therapy? Like, do you think it is most of your patients, you go to the proton beam or the regular external radiations?
I do not do proton usually.
You don't?
I did not show you, but in some case I sent to the cyberknife center after second surgery. If there is some tumor around the pica, I sent him to the cyberknife center. It seems working so far, but we have to wait a few more years.
You mean rather than the craniospinal irradiations, or you do only the focal radiation?
I'm sorry. We did the craniospinal irradiation.
I see.
And after second surgery, still there's a remnant. So that, yeah.
Okay, so sorry, maybe some confusion about my questions. In your first therapy, you prefer to go for the proton beam or is it light?
No.
Is the regular proton is all right?
Yeah.
What is your any reason you avoid or prefer to the standard radiation therapy?
It's up to radiologist, not by me.
Okay. But you think there is no benefit from the proton beam?
Some people said it's better than the photon, but some said not. So personally, I think it's still controversial. Maybe we should wait a few more years. Don't you think?
I think so, but you know, in Korea, some of the mothers ask us to go for the proton beam. We don't have proton beam, but we have some two place. So somehow the question from the parents, we have to send them to the proton beam.
Yeah.
I don't know the other countries, but it's a very limited
Actually, we have
resources.
actually we have a similar situation here, but difficult
Thank
to
you.
answer. Thank you.
Thank you.
We have to move on to the next talk. So thank you, Tucker. Thank you very much. Can I
Thank you
now
very much.
introduce Dr. Mazumdar,
Yeah,
who's
Oui.
going to speak on pilocytic astrocytoma. So welcome.
yeah. Thank you. Can you? Good morning. I don't know. Can you see my presentation? Is my presentation visible?
Yes, Datta, it is
Yeah.
visible.
Oh, okay. Okay.
Please go ahead. Yeah.
Yeah. Thank you. Thank you, Dr. Wexner and Dr. Dev Pujari for giving me an opportunity. So this is a topic which is of great interest, and I was told to give a summary on pilocytic astrocytoma in children. And as you know, this is a vast topic and which encompasses the midline tumors. So I would go still. I'm of the opinion that glioma is still a continuing challenge and a mystery. This was published in 2009, and it was an editorial. And I think in 2022 we are still not being able to solve this mystery to the fullest. So, pilocytic astrocytomas are most common in children, and males are slightly affected more than females. You know, it is a miss in the 0 to 19-year-olds. It is the most frequent primary brain tumor. And as you see, until 14 years of age, the incidence is about 17.6, and till 19 years, it is 15.4 as per the CBT-RUS report from the US. They have a very insidious onset, and everybody knows slow growth. They present with ataxia, cranial nerve deficits, raised intracranial pressure, and sometimes with endocrine symptoms, depending upon the location. So the commonest location for pilocytic astrocytoma is obviously the cerebellum, and followed by the anterior optochiasmal hypothalamic region, sometimes the thalamus, sometimes in the brainstem and the spinal cord. So they can present in various ways. So here the patient presented with a posterior tumor with a syrinx and Chiari. So obviously the Chiari and the syrinx were the secondary effects, and the primary treatment was aimed at removal of the tumor. Complete excision of the tumor was achieved. The syrinx resolved. The Chiari ascended. So the treatment was complete. It was a pilocytic astrocytoma. It was kept under observation, and the patient is quite doing well. This was published in Child Nervous System way back in 2006-7. The pilocytic astrocytoma in cerebellum, which constitutes about 60 to 70%, can present in various ways. You can see here it's present with cyst with a mural nodule. Sometimes you can see that there is an enhancement of the cyst, but this is a gliocyst. This is not the tumor. If the enhancement is thick, irregular, it is most likely tumor. So the aim of excision is gross total excision, and you have to remove the tumor along with the capsule, which if possible should be removed completely. Maybe what is attached to the brainstem or the low fourth ventricle can be left behind because we don't want to incur any vascular. So the message is quite clear that even in cases of completely in a solid cystic or even solid tumors, the main aim of the tumor is gross total resection with no new neurological deficits to the patient. Here is a solid pilocytic astrocytoma, completely solid, a different ball game altogether, because here you see most of the times there's a sliver of tumor which is attached to the brainstem, and maybe you need to be conservative in these cases and not do too much of a radical excision. So safe radical excision as much as possible. We need to understand this in a greater detail. So most of the time, the pilocytic astrocytomas are typical. Sometimes they are atypical. We see mostly now pyelomyxoid variants. Again, in pyelomyxoid variants, they can be typical or intermediate, depending upon the pathological substrates about mitosis, cellularity, pleomorphism, and the K67 indices. Anaplastic pilocytic astrocytomas are known. They can also present with primary leptomeningeal gliomatosis with a minimal posterior fossa extension. And obviously, as you know, they can be associated with familiar tumor symptoms like NF1. So apart from that, the differential diagnosis is important if you don't pay attention to normally. So a ganglioglioma can mimic a pilocytic astrocytoma. RGNT can mimic a pilocytic pleomorphic xanthoastrocytoma and pilar glaucys. Mind you, all these things are differentiated on today on the basis of molecular genetics, which I'll just come to. And this is even difficult for the pathologist to differentiate sometimes between a pilocytic astrocytoma and these four tumors. One aspect which is close to fibrillary pilocytic astrocytoma is diffuse pilocytic astrocytoma. It behaves more or less like a fibrillary astrocytoma. So it is a WHO grade 2. Mind you, pilocytic astrocytomas are WHO grade 1. So here you can see that we need to do molecular genetics. The BK fusion is evident, and histologically it mimics a pilocytic. But if it is removed completely, the prognosis is similar to a pilocytic astrocytoma. So even if it diffuse PA, if it is tackled in a proper manner, it can be, the prognosis is quite favorable. Anaplasia. So this is a new entity. So anaplastic pilocytic astrocytoma is also known. So there could be four kind of changes in a pilocytic. It could be a pilocytic-like looking cell with hypercellularity and brisk mitotic activity, or it could be poorly differentiated. That could be epithelial or rhabdoid types. And sometimes it mimics a classical, just as I mentioned, a diffuse fibrillary infiltrative astrocytoma. The presence of anaplasia, mind you, focal anaplasia in pilocytic astrocytoma is known, but if it is a diffuse anaplasia, then the presence of anaplastic features is associated with decreased survival as compared to typical pilocytic. So the pathologist might just sign it off as a pilocytic. If the patient doesn't do well in a pilocytic, which it should, then these things need to be looked at closely. We have to go and be in tune with the pathologist to find out whether there is anaplasia, differential diagnosis, and so on and so forth. So as far as molecular genetics are concerned, it's very clear-cut. We have to have the BRAF fusion. And if it is a BRAF fusion, then it is most likely to be pilocytic or pilomyxoid. And if it is a V600E mutation, then it prevents more of the other glial tumors, just as I mentioned. So molecular genetics, this is a recent classification. So in the familial setting, in the hypothalamus, in the brainstem and the spinal cord, it is associated with loss of NF protein that everybody knows. There we are a little bit conservative. Observation has a keen role, biopsy has a role, and adjuvant treatment takes more precedence over these patients. In sporadic cerebellar pilocytic astrocytoma, which is comprised of 80%, there are different kind of fusions. So the most common fusion is on the BRAF fusion on the 7q34. And there are different type of fusions. Now, as I just mentioned, these three type of fusions are known, and there may be other type of genes as well, the SRGAP3, and obviously sometimes the hypomethylated genes are also seen in addition. So all these things need to be done, if possible, in a setting so as to know that we are dealing with a juvenile pilocytic astrocytoma. Sometimes in supratentorial pilocytic astrocytoma is also known, but in those the BRAF V600E mutation will be present. So all these things are related to the MEK pathway. There is an alteration in the MEK pathway along which the molecular targeted therapy is also directed. But mind you that this pathway does not affect the outcome. So whatever may be the pathway, the outcome is unrelated to the prognosis of the patient. So here, as you say, this is a recent paper in Acta Neuropathological. You can see how confusing it is. But still, if you see in infratentorial lesions, the BRAF fusion, the BRAF fusion just I mentioned, is quite significant to the tune of almost 80 to 90%. So in pilocytic astrocytoma, I think it is a must to do a BRAF fusion, which almost certainly puts it as a pilocytic astrocytoma. So management is obviously surgery, and you should do gross total excision. If the patient has got a residue, you can do a scan in say 48 to 72 hours. If there is a residue, a second look surgery definitely is a must. Sometimes, if there is a subtotal excision inadvertently, or if the surgeon feels that it is quite adherent to the surrounding structures, then you need to, and if it is a pilocytic astrocytoma, there is a role of close observation and follow-up of these patients with repeated serial scans. And if there is a growth, then again you need to do surgery. So I think surgery is the mainstay for pilocytic astrocytomas. Obviously, if hydrocephalus is present, then there are various series in the literature with various opinions. So I personally do not do any CSF diversion procedure unless it is a persistent post-operative symptomatic hydrocephalus. Mind you, there are case reports of pre-resection ETV, VP shunts, post-resection ETV, post-resection VP shunts, and it can vary from 2 to 15% in the literature. But personally, I feel if we tackle the primary tumor quite well, the need for any CSF diversion procedure is absolutely minimized. And in our situation, the dictum is that as soon as the patient of a posterior fossa tumor arrives on the service, it is operated within 48 to 72 hours. So the most of the problems related to hydrocephalus are obviated if you decompress early. As I just mentioned, if it is a persistent post-operative symptomatic hydrocephalus, then only I need to do a CSF diversion. Obviously, if there is I heard the discussion, the newer modalities of treatment of IMRT, proton beam stereotactic radiosurgery have been introduced with the results are still modest, and the radiation should be avoided as far as possible. So adjuvant therapy in pilocytic astrocytoma is certainly considered if the child is less than 5 years old. There are various protocols, carboplatin, vincristine, and so on and so forth. If there is a primary leptomeningeal dissemination without local recurrence, you consider chemotherapy. Radiotherapy is considered for older children. As I said, it is mostly avoided. But for infiltrating, partially resected, or persistent recurrence, you can consider radiotherapy. Radiotherapy is not safe. In the 2023 large multicentric study, it has been certainly found that radiotherapy has got long-term neurocognition, malignant transformation, and radiation into side effects. So radiotherapy should be avoided as far as possible. And we have molecular targeted therapies for pilocytic astrocytoma. Still, the results are modest. So sorafenib, vemurafenib is still being advertised. There are various combinations, vinblastine, temozolomide, bevacizumab is being tried. And mind you, this is a recent article in 2021 where it is mentioned that chemotherapy or radiotherapy is associated with decreased overall survival. So mind you, in pilocytic astrocytoma, the dictum is surgery, 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 and only when surgery fails, we have to resort to other treatments. So I would just go to the other aspects. You can see that long-term effects in pilocytic astrocytoma. 80% of the people have normal schooling, although they may have mild cerebellar dysfunction or mutism to a small extent. So basically, the long-term results are good. 10 years survival rate is close to 97%. So certainly, surgery has its own aspect. We had done this study of 102 cases of pilocytic astrocytoma in cerebellum way back in 2001, and we have also found the same thing, that the role of adjuvant therapy is still debatable, and still it holds true, and total excision is a better result. So prognosis, the mortality is very, very low. As I mentioned, if sometimes by observation also there is a spontaneous regression of the tumor. So we don't know what is the mechanism, but it could be an apoplectic mechanism or inhibition of angiogenesis or interference with the blood supply. So here is a 20-year-old midbrain exophytic pilocytic astrocytoma. If you see that there is the patient presented with raised intracranial pressure, patient underwent a CSF diversion, and you can see that this tumor is going way up into the tectum dorsal midbrain, and a subtotal resection was done. Now, this patient was operated in 2019 without any adjuvant therapy. And you can see in 2022, the patient is again presented with a recurrence or maybe a residue which has increased. And patient has presented with abnormal behavior. Patient is absolutely otherwise fine. He's a 20-year-old. He's walking, talking, eating. There are no cerebellar signs, but he's only with abnormal behavior. So this patient, we have just thought that this patient needs we ruled out any spinal dissemination, and CSF study was normal. So we have referred this patient to the adjuvant therapy for either a chemotherapy or a radiotherapy protocol. Here is a 12-year-old girl who has presented with headaches, a large thalamic pilocytic astrocytoma, which was operated through the middle temporal gyrus approach. The cyst was evacuated and the subtotal excision of the tumor was done because it was attached to the thalamus. And if you can see, within 1 month, the patient had recurrence. So when we operated this patient again through the same approach, and the report came as pyelomyxoid. So initial report was JPA. The second report came as pyelomyxoid. Then we sent her for radiation, and we have after she presented again with residual hemiparesis, and again we had to go and do the surgery. So this is the second time we had to operate, and then we could achieve a gross total resection, and the patient underwent radiotherapy. And this is the patient after 5 years. So this patient operated 3 times and without any radiotherapy, without any chemotherapy, just with surgery and radiotherapy. The patient is 5 years without any recurrence now. In optochiasmal gliomas, there is again a controversy, but mostly adjuvant therapy takes precedence. And we had done this study. There are various issues affecting quality of life in hypothalamic juvenile pilocytic astrocytomas, hydrocephalus, hypopituitarism, grade of the tumor, extent of disease, and of the involvement of the hypothalamus and visual apparatus. So we have done a qualitative study of 73 ophthalmic gliomas where the tumor was massive, subfrontal approach was used, and biopsy was done in 70%. So if you can see, these were the neuropsychological studies which were done, including mental, social, emotional, and their daily activities. And okay, so this was the outcome measure response. So even if large hypothalamic gliomas are there, they respond very well to radiation and chemotherapy. So there is no reason for you to go and do extensive debulking of these tumors with risk to the patient. So here, if sometimes you get surprises, where it could be a high-grade tumor when we are thinking about a low-grade tumor, or sometimes it could be a mature teratoma. So here, biopsy is a must because we need to know the pathology before we send it to the pathologist. And here we did the outcome measures. You can see over a long period of time, over 10 years, these patients have improved over all social domains, including vision, including their daily activities, including their ambulation and bed transfer, including all the scores were high on the Barker's index. And obviously, when they develop a long-term radiation complication, one patient developed Moya disease, and you see that the quality of life has gone down. So here, that's the reason I'm saying that radiation has to be used carefully in these patients. And the neurocognitive assessment was done. We found out the neurocognitive assessment of this patient is low even before we start radiotherapy. So radiotherapy cannot be blamed always. So the tumor itself with its attendant side effects causes a low cognition, which radiation may accentuate, or even, but the quality of life is definitely improved across all domains in this patient. So I think in patients where we could not offer too much of surgery, like the midline hypothalamic gliomas or the brainstem gliomas, radiation does offer a role. But in cerebellum, definitely the surgery is the mainstay of the treatment, even if it has to be done twice or thrice. Thank you very much.
Thank you very much for that. It was very, very comprehensive. We are a little bit over, but there was one question that I think we should ask, because I agree with you. When you have these children, we also try to operate within 24, 48 hours of their presentation to hospital, but that's because we have the facility to do so. One of the questions that was raised, when you are in a situation where it could take 1 to 2 weeks before you can have access to theatre, because that's the resources that you have, and they come in with hydrocephalus. Do you have a preference for how you manage the hydrocephalus if that was your situation?
Yeah, so if the patient is for some reason, if we cannot operate this patient for 1 to 2 weeks, then certainly I would make this patient indoor, give steroids, and if the hydrocephalus is the predominant symptom, then definitely I would plan either an EVD or do a VP shunt. In our setting, in say India, for example, in the setup that I work, a VP shunt would work better than a EVD because I'm worried about complications of EVD in 3 to 4 days. So I would do a ventricular peritoneal shunt or an ETV if possible, rather than an EVD. If the patient is to be taken in 2 to 3 days time, I would do an EVD. But if it is 1 to 2 weeks, I would prefer a permanent CSF diversion.
Okay, thank you. We might leave any more questions to the case discussion. So we're moving on to the case discussion, and we have cases from members of the faculty for this session. But I'd like to invite Dr. Singh to present the first case.
Virginia, as do you think I should present a case first?
Very happy for you to do so if you like.
Okay. And Dr. VP Singh, who's not the speaker for this session, has one case to show, as and when you have time for him. So continuing the theme of craniopharyngioma, I would like to share this case. This is a 4.5-year-old girl who has presented with this lesion, and she has essentially presented again with raised intracranial pressure, headache, vomitings, and she's a little short for her age, but otherwise quite well. Before I go to this, I would like to ask the audience and the faculty to make a comment as to how they would treat this girl. She has had a vision loss in right eye, as you can see from the notes made here.
Do we have more images?
Sorry?
Do we have more images? Sage, coronal?
No, I have not put more images.
Okay.
So as she presented with headaches and vomiting, we went ahead and did an endoscopic insertion of Omaya reservoir. Because we don't get a peel away sheath, we have this little bit of problem where we have to clean the tip of the endoscope after insertion. And then I opened this cyst and put in a reservoir, and this is where we stopped. And we then started using intracystic interferon in this patient. And after her treatment with the protocol of interferon therapy, this is the lesion, as you can see on the CT scan after 3 months. She's completely relieved of her symptoms. She's completely asymptomatic. Her vision in the right eye had gone almost a year ago, which they revealed later, and that did not improve, but there were no other field defects and there was no other symptoms. So what do we do at this time?
Could I just ask a question before there? Do you find, do you get much leakage if you've inserted the reservoir with an endoscopic approach? Because I'd imagine that the diameter of the hole would be quite large. Is that an issue that you find?
It has not been an issue. What you can actually do is, what we do is we use a bipolar or unipolar cautery tip to make the small coagulation, and just use that to make the hole, and then follow it with the catheter, which goes with a stylet. Usually the the ply, what is it called? The stylet of the EM navigation works well to insert into the cyst. You also have a navigated kind of insertion, and at the same time, it's thin enough not to create too big a hole.
Did you have a biopsy confirm on this patient?
Well, it's a very, very clear craniopharyngioma fluid, machine oil kind of a fluid. So I do not think we performed a biopsy in this case.
Dr. Diopajari, I think in this stage, do we need to be the intrathecal treatment? Because I have done many cases of this kind of intraventricular extension of cyst. Why you are the expert of the endoscopic surgery? Why don't you remove the cyst rather than the intracystic interferon therapy?
So that definitely was an option that you could excise this completely.
I mean, not total, but the proposed you do like intracystic interferon therapy is decrease the cyst, right? So why don't you remove subtotal in the third ventricle and then the base and the third ventricle floor? You just leave them.
That was definitely an option. We discussed various options with the parents, and they wanted some minimally invasive procedure. They were offered a major transcranial surgery earlier, which they did not want, and the child was only 4 years old. So,
this is a recurrent case.
This is a recurrent case in the sense that yes, somebody had aspirated the cyst once before me. Somebody had already aspirated the cyst once before they came to me, and then offered them a major surgery to go for a craniotomy. And I said that if you do not wish craniotomy, then this is an alternative. Because she was less than 5 years old, we did not send her for radiation, and she was symptomatic.
Yes. So after
at this stage, I offered them again that I think surgery is going to be easier now, or you can now go for radiotherapy as and when there is some increase in the cyst. And by this time, I think they had made up their mind and they decided to go ahead for surgery. So this is exactly what I did. The first time somebody had already done this, I removed the cyst, and through the same hole, we went with an endoscope assisted surgery, and we managed to remove. The advantage of interferon, apart from the fact that the cyst shrinks, I think the wall becomes tougher and it is easier to achieve excision, like it happened in a very short time in this case. And this girl tolerated the surgery quite well and could literally be discharged in a week's time. And this is the post-operative scan. Now it is about a year, and there is no recurrence. So she's still awaiting with the yearly scans to see if she requires further radiation or not.
So I questioned about your approach is very small, like a ball size. You are the kind of master. And you just take the tumors from the mono?
Yes.
Wow, that's very good. Congratulations.
So, I mean, I thought if this girl was age was more than 4 years, I would have probably gone in one stage. But here, shrinking the cyst and toughening the wall probably helped in achieving radical excision through the same burr-hole kind of an approach, which made it easier for the patient to recover quickly. Any other comments, Dr. Virginia or anybody else?
There's a question about whether your patient has hormonal deficiencies.
No, the patient does not have obesity. And if you allow me to show the second case, I think this is what we have found. This is another patient, and this patient presented with visual deterioration as well as raised intracranial pressure. and he's 8 years old. And he actually came in a drowsy state in our emergency room with this kind of a scan. Now all images are available. I must find other images of the previous patient if I have to present again. So this is a clearly sellar, suprasellar, intraventricular, all three compartments are involved in this case. And the boy is 8 years old. And he's pretty drowsy at this time of presentation in the intensive care. Any suggestions? So what we have started doing again in these cases is we have several choices how we go for this patient. But looking at the patient's condition, we started him on dexamethasone. He presented around 4 in the afternoon. Next morning, we took him up. Again, did the same procedure. Rather than putting a EVD, we went in with the endoscope. We inserted, I think there's nothing much to see here. We inserted a catheter. As you can see, it is precisely fitting into that area, and we do not allow too much spillage of the fluid. But I think under cover of steroids, if some spillage occurs, usually so far we have not faced a problem of aseptic meningitis. Then this patient was worked up fully hormonally, and CT was done to check if we had a good access through the endonasal approach. And in 3 days' time, this is the scan after the placement of the reservoir, and then we went endonasally to achieve the excision. You can see the cyst, you can see the normal pituitary behind, and you can create a plane between the pituitary and the tumor. And this is how the cyst is separating. One of the big advantages of draining the cyst from above is that it is much easier to separate the cyst from the wall of the third ventricle, including the hypothalamus. And you really need just a gentle tug. You can see how nicely it is separating just with a gentle suction being used as a dissector. That is a catheter which we had put in, and a complete excision has been achieved. And this is the normal gland, and this is the stalk which is still intact. And this patient required EDA-VP for about a week's time, but was discharged with a small dose of Minirin and steroids. And this is the scan done 3 months later. By this time, he is off Minirin completely, and a complete excision has been achieved. It's about 2 years now, and there has been no recurrence. And we have now done about 29 cases with this kind of approach in a patient who presents with hydrocephalus and a cystic element, where we first do a transventricular aspiration, leave the reservoir, and after 3 or 4 days, when the patient is more stable, then we go for an endoscopic transsphenoidal kind of an approach to remove this. So what we are saying in summary is that in emergency setting, instead of undertaking major surgery immediately, you can relieve the intracranial pressure not by EVD, but by doing a cyst drainage, and then you can use your logical algorithm, either transcranial or transsphenoidal, and the tumor separation from the third ventricular wall and hypothalamus becomes much easier. And the maximum benefit of this procedure is in raised ICP patients secondary to a large cystic craniopharyngioma with hydrocephalus. Thank you. And these are the patients actually who have undergone this kind of procedure. You can see that though the height is not appropriate for age, none of them have developed premorbid obesity. These are 5 of these patients.
Excellent. Thank you. We might move on just in the interest of time. Then to Xiao to present a case.
I don't know.
I'm here. Okay. All right. Let me just share my screen. Straightforward case, I think. Okay. So just one case to discuss. Right. So this is a case for discussion. This is the 11-year-old boy, headaches for a week, vomiting for 2 days, complaint of neck tightness. And this was the scan that was done right? And then followed up by MRI same day. So obviously this is a pineal region tumor, right? So what's the first step that we will see when we do this, see a case like this?
Like you suggest,
Okay.
ETV and biopsy.
Wait, you must do markers first, right? But of course, I mean, there's hydrocephalus to be treated. Yeah, right, Dr. Yang, right? So, so if it's a serum negative, what does this mean? Well, I mean, it's not a secretory germ cell tumor, but it can still be a germinoma. Although, actually, when you look at the MRI, you see all these cystic areas. There's a high chance that there is actually a teratoma of nature, right? And this is quite usually you see this. So we do, let's say, ETV, and then we biopsy. The problem here was that he improved after ETV, but the biopsy was not definitive. So what else? What can we do then? I think with a tumor like this, right, the next step actually is to really do surgery. And we went from the infratemporal supravellar approach. Intraoperatively, it was a heterogeneous tumor with varying consistencies. There was some tumors material consistent of cheesy, hairy, solid tumor. So this obviously was a teratoma. And then there was also soft grayish components. The final histology was that of a mixed germ cell tumor. There were components of germinoma and a benign teratoma. So although the patient, you can see the tumor looks beautiful, the surgery looks very nice on the photo scan, but actually this patient still had a loss of upward gaze. He was actually drowsy for quite a few days because, almost 2 weeks, because yes, he ended up with a right thalamic infarct, not so obvious on the scan, which and then slowly, I mean, he recovered, but he still has quite significant, gaze palsy. So the point is that if you do surgery here, your risk of actually damaging the tectal plate and tissues there, and also vascular areas causing infarct is actually quite common. So you got to be very careful, especially in a very big tumor. And then he, of course, he underwent chemotherapy and radiotherapy because there was a germinoma component as well. And so that's really my case to share with you. Thank you. So try to answer some of the things that I talked about earlier.
Do we have any questions from anyone?
Yeah, one, two. It's a very good case. And I have a question about when you have not very helpful biopsy result, why don't you go for the chemotherapy? If there is any suggestions?
Okay, so I think, I mean, in the past, what we might think of is they see a germ cell, you see a lesion in the pineal region, the markers are negative, can this be a germinoma? And actually, in the past, before we had chemo, even like the better chemotherapy, all these patients actually went for radiotherapy. You go for radiotherapy for 2 weeks to see whether the tumor shrink or not. If the tumor shrink, then you say it's a germinoma, then you continue the full radiotherapy. But I think in this day and age, we probably try to avoid, because that sort of radiotherapy is not like a full, it's not the way we do it now. Nowadays, I think germinoma, you might just give radiotherapy within a, paraventricular and also around the pineal region. That's it, right? Whereas last time you actually used much bigger doses of radiation. So I think, but if you look at this case, to me, it's very clear that there's probably a germinoma component. And so I would, in this particular case, and really, if you even do a biopsy, you might still think that if you probably get a germinoma component and then you still go for the treatment, you might still go to have second look surgery. So for this particular case, this is where, and I think some of our Japanese colleagues, when they see lesions like this, they don't even worry about, taking biopsy, they actually go for surgery straight away.
Okay. So I have similar cases, but my question was, if you, before surgery, you just convinced that is a benign teratoma, most of them. And those cases, you can go straight forward for the surgery. But if you have staycation, I think maybe someone prefer to go for the chemotherapy first.
Sure.
And then
I mean, I think
the other,
I mean, these are things that you discuss with the oncologist. They have their protocol, and then you will decide what is the best thing to do. But I mean, obviously, this tumor, to me, I didn't get a conclusive histology, and definitely teratoma was, way there on the, provisional diagnosis. And I know that if it's teratoma, at some stage you need to do surgery anyway. It's not going to shrink down very much because you can see the size of the tumor. So, but I think you're right in the sense that sometimes if you see things mixed, if you give chemotherapy, the tumor actually shrinks. So then you actually have much easier to do the surgery as well.
Thank you. Good case.
So there are two questions. One was, if tumor markers are elevated, so beforehand, do you agree that you wouldn't do a biopsy once you've done the ETV?
Okay, so you go back to what I said earlier about, histology is probably better than than no biopsy. And in this case, actually, we did a third ventriculostomy and tumor was there. So I would carry on and do a biopsy.
Okay. And the second question was, what approach did you use for surgery?
Okay, so we use I did a supracerebellar infratemporal approach, and we didn't have the patient sitting in. Actually, we did a Concord position for this patient. So you can do, it's almost, I think most of the people here should be aware of what the Concord position is. Patient is prone, head actually usually tilted to the other side, and then it's elevated so that the head is a bit elevated, but not in the sitting position. I think it's actually not very good for the back, but it's actually not as bad, in my opinion, as a sitting position, because in a sitting position, you actually have to stretch out like that, right? But whatever it is, I can tell you all pineal surgery is bad for your neck and your back. Surgeon wise.
All right. We might move on to the next case. Thank you. Thank you. Dr. Shihum Yang, would you present, please? I think you're muted, so if you could unmute yourself, thank you.
Sorry. So can you hear me now? Yeah, okay. So this is a case of a secondary neoplasm in pediatric brain tumor patient. It's a 11-year-old girl with headache, vomiting for weeks. The CT scan and MRI show a posterior fossa tumor with hydrocephalus. So an operation was done to remove the tumor subtotally, and the pathology showed an aplastic ependymoma. But the post-operative MRI of the spine shows lumbar sacral spine seeding. On the right MRI, you can see in the right posterior cecal sac there is a oval contrast enhanced lesion. Therefore, according to the protocol, she underwent a cranial spinal irradiation, but she actually went to another hospital. But she became disease-free for 10 years. Then at the age of 21 years, there was a right anterior neck mass. And the next sonography showed a thyroid tumor So she underwent a total thyroidectomy, and the pathology revealed a papillary carcinoma. Iodine radioisotope ablation therapy was given. So in summary, this 11-year-old girl with posterior fossa anaplastic ependymoma and the CSF dissemination had tumor resection and cranial spinal irradiation. Then 10 years later, she had thyroid papillary carcinoma. So the first question is her thyroid cancer a secondary neoplasm? So I don't know if anyone want to say something, or everyone can have your answer in your mind, and I will discuss. So of course, anyone without brain tumor can have thyroid cancer, but in pediatric brain tumor patient, there is a meta-analysis for children with medulloblastoma receiving cranial spinal irradiation. So usually we know there will be secondary tumor in the CNS, but actually there are some tumor that may arise outside the CNS. So it could be a secondary tumor for these patients, thyroid cancer after treatment for the ependymoma. And the average percentage is around 3% for the benign tumor, and also around 3 to 4% for the malignant tumor, and both can arise within the CNS and outside the CNS. And among the tumor outside the CNS, actually thyroid tumor are the most common, because I think the cranial spinal irradiation might cover the field in the neck and chest and abdomen, and the thyroid is a very radio-sensitive tissue. So many secondary tumor outside CNS are actually thyroid tumor, including adenoma and carcinoma. Question number 2. So for secondary tumor inside the CNS, what are the most common ones? So there, I think most faculty should already treat many brain tumor patients, so must encounter some of the secondary tumor in the CNS. So for a paper published by the Taipei Veteran General Hospital with more than 600 cases, the most common CNS tumor are meningioma, sarcoma, and high-grade gliomas. And question number 3, what are the risk factors of secondary neoplasm in pediatric brain tumor patients? So in that study, it was found that younger age and also cranial spinal irradiation will result in higher chance of secondary neoplasm. So this is the comparison between cranial spinal irradiation and no cranial spinal irradiation. So we can see the chance of secondary neoplasm is much higher for the patient receiving CSI. And how about the modality of radiotherapy? So in that study, they compare the 2D radiotherapy and 3D radiotherapy and image modulated radiation therapy. And actually, there is no statistical significance between the different modality, although the 2-dimension radiotherapy seems to have higher tumor later in the years. And in the previous discussion, that some faculty mentioned about the proton therapy, and we know proton therapy can use their special effect called Bragg effect. So the radiation will stop at the target, and the tissue behind the target will have much less radiation. So for the image shown on the right lower graph, the craniospinal irradiation, the tissue anterior to the spine will have much less radiation compared to the other photon therapy. So will this confer into less chance of secondary brain tumor? So there is one study comparing patients undergoing proton versus photon therapy. So for patients with proton therapy, there seems to be lower chance of secondary malignancies, but there is no statistic significance in this study. And this year there is a meta-analysis comparing proton versus photon therapy for primary CNS tumors. So again, the most common tumors are glioma, meningioma, sarcoma, and also thyroid cancer as shown in this case. The rate of secondary malignancy for proton beam therapy is 1.5%. And for photon-based radiotherapy, it's 1.8% in this meta-analysis covering more than 38,000 patients. Is a very large meta-analysis. And this difference between photon therapy and proton therapy is, again, not significant. And for patients with proton therapy, there is a shorter latency to develop secondary malignancy. So as the discussion previously, there is still some debate about the real advantage of proton therapy. I think it's discussed by Dr. Taga and Dr. Shin. Thank you. That's my talk.
Thank you. Do we have questions from anyone?
Yeah, congratulations to save this young girl with the craniospinal radiations.
Yes.
Yeah, can you hear me? And then I have only a few cases of the saved life, the grade 3, malignant ependymoma. And I have questioned how much dose you gave for the craniospinal radiation in case of craniospinal seeding. Do you remember? Do you know how much dose of the radiation dose?
Yeah. Actually, this patient went to another hospital for the craniospinal irradiation. So sorry, I can tell you, the real dose of the craniospinal irradiation for this patient. But usually I think the radiation oncology will give like 36 gray for the spine, and for the brain, there will be additional dose up to a total of 54 gray, I think.
Yeah. It is interesting. In my hospital, radiation oncologist very skeptical for the palliative radiation therapy. So I have one patient with a recurrent anaplastic ependymoma with a seeding into the spinal cord. But once she had radiation therapy in only the posterior fossa, and then when the recur in the spinal cord, the radiation oncologist refused to radiation therapy for the spinal cord. He think this is only the palliative, not a curative. So I don't understand him, but actually, the radiation oncologist sometimes.
Yeah, I showed in my presentation previously the fourth case. He has a posterior fossa ependymoma, then later have a distal metastasis. Actually, the case is Dr. Mengfei Guo's case, and she shared with me. Then for the later distal metastasis, Dr. Guo removed the tumor, and the radiation oncologist performed the radiation therapy to the spine because the spine was not irradiated, so it can be treated as a fresh tumor. So So it's a pity that your radiation oncologist didn't do the radiation therapy for the patient.
So, any person in the faculties have experience of the re-irradiations for spinal cord or the brain in case of recurrence? It works. I mean, ependymoma.
We use it for symptom control predominantly, rather than
Yeah.
curative intent.
Yeah, only the palliative, right? Okay.
Yeah, sure.
We need to move on, so we can get some more of the cases presented. So thank you very much. That was great. Can I ask Dr. VP Singh to present this case, please?
Thank you, Virginia, for this opportunity. Right. Just sharing my screen. So this young boy came to us in August 2008 with seizures, and there was this sort of solid cum cystic lesion, a brightly enhancing lesion, periventricular. Part of this is a cyst, and maybe part of this could be a part of the doculated ventricle. And those are the scans. So a clearly when demarcated lesion, we thought it's a pilocytic astrocytoma. We went in and operated this patient. What we thought was a complete excision. To our surprise, when we did a scan a month later, we found this enhancement here. Now the biopsy was a pilocytic, so the question was, should we go in, do a second look surgery and take the whole thing out? Because that is what is recommended. I mean, it's a benign tumor, a complete excision is what is necessary. So we gave the patient this option, the family, but the family was reluctant for a second surgery. So we followed up the patient. This was October 2008. In 2009, to our surprise, we found that the enhancement had significantly reduced in size. So it was probably a post-operative enhancement which has reduced in size, and we decided to follow up the patient. And this is the child, a happy child with no deficit at that stage. 2 years later, after the first surgery, we found that the lesion has started increasing in size. And so again, the child was absolutely intact, and we offered them surgery. The family was still reluctant, and we continued to follow up. This is in 2011, the tumor was almost the same size. There was no further increase. 2012, about the same size. And that was the patient who was happy and sort of without any deficits. So in 2013, we found that the lesion had started increasing further. So the lesion had come back. It was static for 2 to 3 years. And then he was regular in his follow-up. We found that it had started increasing again. And so this time there was, although the patient was intact, there was a very definite increase, and we prevailed on the family to accept surgery and go ahead with the surgery. And so November 2013, that is 5 years after the first surgery, we decided to go in, and we were able to do a complete excision of the lesion. And January 2017, we followed the patient up. It's now about 9-10 years since the first surgery, and the patient continues to do well. So the lessons learned from this case was that post-op contrast enhancement is not necessarily a tumor only, especially if the scan has been done in the early months after the surgery. It could be a post-operative enhancement. One has to be careful. If you are in doubt, do not reoperate. Just follow-up scans would help us know the nature of the enhancing lesion. The delayed enhancing areas are also not necessarily tumors. If radiation has been given, there could be radiation change. In this case, of course, there was no question of giving radiation therapy. But in certain other tumors where radiation has been given, we do see delayed enhancing areas which come up later on. So do perfusion spectroscopy, and if in doubt, and the patient is clinically well, do follow-up imaging, and often it manifests and we know what it is. So that's one case, and I have a series of cases. I didn't know how much time I had, so I got a number of cases of thalamic tumors, but if there's time, I could do that.
Ideally, it's just one.
Right. Okay.
But can I ask you a question? What stopped you in the first resection? What was the? Is it the tumor margins were ill-defined, or what was the reason for stopping in the first?
When we thought what we done was a complete excision. I mean, we didn't think there was any tumor left, and it was to our surprise that we found that enhancement in the post-operative period scan.
Because one of the questions then, because it's often posed, if you've done that first resection and then you've still got residual and you're asked to go back, because one of the questions to us is, well, if we couldn't do it the first time, what are you going to do differently the second time? And I agree with your watching, because I would have done the same. What would you do the second time to try and change that, do you think? Was it different when you came back for the larger recurrence?
When in the initial phase, we didn't have the intraoperative MRI at that time. Now we have. So I think if you have an intraoperative MRI, that would help you in making sure that the excision is complete. And now with the availability of the intraoperative MRI, we do it routinely.
And Dr. Mazumdar is asking, what was the biopsy in the second surgery?
It was tenopilocytic.
Can I just, for a minute, Virginia, I think this also puts one question to us. What is the ideal time to do post-operative imaging? I think most of us believe, and I think most places have protocol that if you want to see a benign pilocytic kind of a lesion, the best time to do post-operative MR is probably within the first 24 hours. And if that is not possible, you wait for about, we usually wait 10 to 12 weeks. But is there some kind of a consensus on this? Because otherwise it is subject to misinterpretation, like what happened in this case.
So we're the same. Usually, if you do want to do it, within 24, 48, otherwise 3 months. Yeah, that's our protocol.
I think I have a question about when the diagnosis of parothelial is very well circumscribed in the benign, like not the benign, but like the benign course and the low-grade glioma. So we have to think about in the radiosurgery too. Have you think about in the radiosurgery if there is a small like residual or small recurrence of a parothelitic?
When radiosurgery is also described to benefit, but this was a young child, and I would be hesitant to give radiosurgery. I mean, although we started radiosurgery in India a long time back, but in a young child, you're always hesitant. If there is a surgical option, I would prefer that because of the long-term results. I mean, we talked about the second tumor, which is a secondary tumor. So in a young child, if surgical excision is possible reasonably safely, I would prefer it over radiosurgery.
So thank you very much. Tucker, would you like to present your case?
Okay.
Dhaka is in a wonderful place, I must say.
I cannot share the screen.
Dinesh, can you allow sharing? Virender, VP, have you
already given, sir?
Okay. Has Dr. Singh's sharing has stopped?
Maybe it's my side problem.
Just can you try once again, sir?
There are two takas, so make sure you give the correct.
I think the Apple doesn't sync very well with Zoom for some reason.
Sorry, Virginia, I need some time to share the screen.
So maybe we might ask Dr. Mazumdar to present his case.
Yeah.
Is that okay?
Datta, are you there? Have you got a case?
No, sir, I don't. I have just discussed these two cases in my talk, so I don't have a case per se.
Right. So maybe till Taka gets ready, can VP show one more case?
Yep, that would be fine.
Yeah.
We have about 10 minutes left
he's-
for the session.
Taka is back.
Oh, Tucker's back. Perfect. Okay.
Thank you. This is 6-year-old boy. He was diagnosed as ADHD at the age of 3.
Taka sir, you joined with the 2 device. Kindly mute one device, please.
Oh, sorry. Working?
No. Echoing.
Okay. Forget about it.
Just you need to mute. I can see the both the devices unmute. I'm going to mute one device, and as well as just you can switch off the sound also.
Okay.
That's why it's echoing a lot.
Sorry about.
Yeah. Now can you speak, sir?
Something is not okay for my side.
Yeah, okay. That's okay.
We can
Do you hear me?
see you quite well now.
Yeah, go ahead.
Okay. A 6-year-old boy came to us. He was diagnosed as ADHD at the age of 3. He was easy to be irritated since he became 5 years old. And the mother told us his behavior was changed drastically. And this is the, oh, sorry, that's my problem again. Oh, I shared wrong one. I'm very sorry. Let me use this one. He has a cystic lesion in the posterior fossa. I wanna discuss with you is the approach of the how to approach this tumor and what is the diagnosis? Is anyone has any idea? It is
Cystic astrocytoma transcerebellar.
Other than pilocytic astrocytoma?
Desmoplastic medulloblastoma. Or what is that nodular medulloblastoma in your classification?
How about the surgical approach?
Either transcerebellar or through the CP angle.
I prefer to go there through the transcerebellar, but my colleague insisted CP angle approach should be better. But personally, I think it might be the pilocytic astrocytoma. So transcerebellar might be the better approach.
Yes.
But maybe CP angle approach could work fine too. But anyway, it turned out to be a pilocytic astrocytoma. And without any further treatment, he was free of disease afterward. And
then it will not be shown as a case. So something else happened.
And this is a very similar picture to the one just we heard from previous talk. What do you think? How much do we need to remove the tumor? Actually, I did partial removal. It was between grade 1 astrocytoma to pilocytic astrocytoma. It was the answer from the pathologist.
This is before or after the excision, Taka?
Before.
Ah.
And because it was benign, I waited for a few years. And this is the MRI after follow-up. Now it became malignant because some part started to be enhanced. And it was grade 3 astrocytoma now. So I did stop removing the tumor first time, but even the pathologist said it's between pyelo or grade 1 astrocytoma. It depends on each cases. Sometimes it remained pyelo. Sometimes it became very malignant. So
was there any molecular biology done after the first surgery? How many years ago was this?
Around 3.5 years.
So do we have the BRAF status of this patient?
No.
Oh.
It's a short slide.
IDH ATRX or P1P19Q?
Oh, I didn't examine. Pathologist didn't study further at that time. It's all the case.
IDH1 mutation was also not done.
No. So the message I would like to share with you is that we should try to treat each case differently, but scrutinizingly. Otherwise, we will lose some cases. That's my message. I am very sorry. I shared a long screen with me.
Not a problem.
Yes.
Thank you.
But
we
today,
probably have time for just one more case from Dr. Singh, if you'd like to present one more case. And then there will be a break.
In the previous case, till Dr. Singh comes, do you think, anybody has comment? Do you think the molecular biology would have helped us to predict and plan better or give upfront radiation?
I think yes, sir. I think molecular biology in this case would have been very important to differentiate between pilocytic and non-pilocytic, number one, and then plan adjuvant if required, depending upon whether it is depending upon the adjuvant status, or re-resection if somebody wants to debulk and get further tissue for characterization. Neuronavigation guided focal resection of the enhancing component.
Right.
Right. So should I start, Virginia?
Yes, this is the last case.
Right. So thalamic tumors are deep-seated tumors, but they can still be operated. The only thing is a variety of approaches are needed to approach them, and there are various considerations. You have to choose the right surgical corridor, and tractography we find is extremely useful to operate these cases. Although this is an adult, a deep-seated tumor, thalamic tumor, somebody had tried to come from the temporal side, run into problems. We got the tractography done, and we found that this was just not the right approach to it, should have been come from posteriorly. So a small tumor like this, relatively asymptomatic, we just do a stereotactic biopsy. A larger tumor going into the ventricle, an ipsilateral transcanosum is the right approach. You can do a good excision of the tumor. That was the astrocytoma grade 2. A slightly larger tumor, but still not very big. Again, a transcanosum ipsilateral, and you can get into the ventricle, get into the tumor, and take out the lateral margin. But if it's a larger tumor, the ipsilateral approach does not work well, because to take out this part of the tumor from the ipsilateral side, you really have to retract another brain. So there, going from the contralateral transcanosum does make sense. And although it's a much longer approach, you need long instruments, but the chances of damage and the amount of brain retraction which is required is much less. A patient like this, not coming into the ventricle, a transtemporal approach would be an optimum one. You can't get it from the transcanosal. And this is a post-op scan. There was some residue. We weren't able to get a complete excision. It was a pyelomyxoid astrocytoma, but the patient was well. A posterior thalamic lesion like this would best come from the supracerebellar approach. I think any of the other approaches doesn't work. You go from the supracerebellar, you angulate the microscope slightly to one side, and you're able to take it out. This was an oligoastrocytoma. So very briefly, I think what he wanted to say was that even these deep-seated tumors can be operated, can be excised well. A fair number of them are benign, so it is worthwhile doing a complete excision, but we have to choose our surgical trajectories very well. Thank you.
Thank you. That's a great series. Are there any comments or questions before we close the morning session? Or first session, I should say.
Just one question or comment maybe. Yeah, I think Mirna has put that could we have just done a biopsy? But more importantly, the pyelomyxoid word seems to be absent from the 2021 WHO classification. So what is the alternative and how do we differentiate treat today? Anybody has
Sir, pyelomyxoid is not in the WHO, but still it has got its relevance. Because in pyelomyxoid also we have to see whether it is got some low grade or a high grade component. And if it is a high grade component, it has to be treated like any other diffuse glioma. So if it is an intermediate, if it is a low grade pyelomyxoid, then surgery still stands the mainstay. And if it is an intermediate grade, then then we have to do the markers for diffuse glioma and then treat accordingly. So although it is not, it is like gliomatosis cerebri, although it is not included in the WHO classification, still for the clinical strategy, we have to use this. And pyelomyxoid is still used in the recent papers which have been like 2021, 23 papers, where still it is being currently used.
No, I understand. The main reason I'm bringing this forward is that I think we are going to have update on these classifications virtually every second year, and it's going to be more and more difficult for, at least at my stage, I think it's going to be more difficult to understand and decide about treatment.
Sir, I asked for neuropathology. Yeah, sir, I asked for neuropathology. Even they find it difficult now to comprehend all types of, almost each person, tumor has got his own signature now. So it is very difficult for the neuropathologists also, liver side clinicians in that aspect.
Any different opinions from Australia, Japan, Korea, Taiwan?
No, I don't think so.
No.
All right. So I'd like to, we might wrap up the first session then, just to let everyone know there's a half-hour break and then we'll reconvene for the section on CSF circulation. So I'd like to thank all this morning, I say this morning, but all the first session speakers, depending on your time zone, for the effort and the fantastic talks and cases discussed. So thank you very much, and we'll see you in half an hour.
Thank you.
Okay. Thank you, sir.
Thank you very much.
Thank you.
Thank
Thank
you.
you.
Everybody.
Thank you. Have a nice break.
Dinesh, any questions, any problems? Dinesh, are you there?
I don't think he is there.
Oh.
At least I don't see his name anywhere.
Are you operating now or you are in a break? You will be there for the whole session, Suresh?
Yeah, now onwards I will be there. Definitely.
Okay.
Till 3 p.m. till it ends.
Perfect.
Okay.
So then we also take a 20 minutes break, I think, and get back.
Yeah, sure.
Dinesh?
Yes, sir.
Do you want us to be on, or can we also take a break for 20 minutes?
No. It's on, sir. So we leave it on only, Dinesh.
Yes, sir.
Yeah. Okay. Okay, then see you after 15 minutes.
Okay, Dinesh, I'll get back.
Okay, sir.
after the break. So we start our second section about CS circulation. So our first talk is about is by Professor Kasik Seo. So please, Kasik, share your screen to start.
Good morning, good afternoon, good evening, wherever you are. And thanks for the opportunity for presenting this in this podium. My topic for today, am I visible and audible?
Yeah.
My topic for today is antenatal and neonatal hydrocephalus. And as you know, sorry, just give me a second. So antenatal and neonatal hydrocephalus, we start with this case. It's a young mother who approached with his husband, and because her antenatal USG showed a mild ventriculomegaly, as you can see, it's marked in the picture. She had a maternal hypothyroidism and was under proper antenatal care, but she was very worried about whether her child was going to be hydrocephalic or not. And both the parents came and meet me, and we are regularly following up the child with the serial ultrasound. As you know, for the fetal and neonatal hydrocephalus, the most common causes are either it is congenital, or it is perinatal, that is post-hemorrhagic, or post-infective after birth. This is a prospective classification of hydrocephalus given by Professor Hui. And this is very interesting because it divides the hydrocephalus according to the stages in fetal and neonatal life. For example, in stage 1, the cell formation is taking place. In stage 4, neuronal migration is taking place. In stage 5, myelination is taking place. For when hydrocephalus is developing, the stage which is hampered most, the child or the fetus will suffer from that disorder mainly. And also, you know, in children, the binder CSF pathways is a major thing. The major CSF pathways are yet to fully develop, and that is one of the things that the traditional treatment for hydrocephalus will not work. The bad prognostic markers for fetal hydrocephalus are if the hydrocephalus is detected in the first 2 trimesters, if the hydrocephalus is communicating, if there is a thin cortical mantle, there is an associated congenital malformations or infective etiology, and the child, the fetus is a syndromic baby. By definition, fetal ventriculomegaly is when the size is more than 10 millimeter at the atrium of the lateral ventricle. It is mild if it is less than 15 millimeter. It is severe if more than 15 millimeter, and it occurs due to cerebral atrophy or malformations like corpus callosal hygenesis. By nature, it is non-hypertensive, that is, ICP is not raised. So the outcome for counseling is easy. It is 14% to 15% progress, 60% around remain stable, and 30% regress on their own. In contrast, the fetal hydrocephalus, there is a raised intracranial pressure. As you can see in this fetal MRI image, the subarachnoid spaces are quite effaced, and there's an increase in the angle between the ventricle and the caudal plexus with edema in the cortical mantle. Fetal hydrocephalus can be, as I've told, primary, like in isolated fetal hydrocephalus, or obstructive, post as a part of the dystrophism syndrome, or a part of the malformations like Dandy Walker, or it may be secondary to bleeding infections or intracranial tumors. So what is the outcome of fetal hydrocephalus? If there's a unilateral ventriculomegaly, the chance of having neurodevelopmental anomalies is around 6%. It doubles if the ventriculomegaly is bilateral, and in syndromic cases, the neurodevelopmental anomalies is around 50%. So what are the fetal infections that we need to be careful? That is especially the torch infections and other infections like parvovirus, Zika virus, hepatitis virus, enterovirus, even some parasite like trypanosoma. Diagnosis is usually made by 3D or 4D ultrasounds, which can pick up ventriculomegalies from 17 weeks. Serial ultrasound is a norm. Fetal MRI, if available, can pick up ventriculomegaly from the 8th week onwards. And for management, you have to organize a multidisciplinary team along with obstetricians, radiologists, and the neonatologists. And the option is to either early termination, if there is time, or early delivery, or the third possible interesting option is to have an in utero correction. This is an algorithm for fetal hydrocephalus. So if there's a severe anomaly, we are in for a no intervention. But if it's without anomalies of the surrounding brain, then we follow up with serial ultrasound. So the ventricles are stable. We take the baby to the term and take a decision there. If there is a progressive ventriculomegaly in utero, then there is an option of doing a fetal surgery. And options of fetal surgeries are to do a serial cephalocentesis or a ventricular amniotic shunt or a fetal ETV within 18 to 30 weeks. The ventricular amniotic shunt is the most commonly described procedure for fetal hydrocephalus. But as you can see, this is a single puncture from the posterior horn into the amniotic fluid with a coiled tube. And but the problem is that because of the coiled nature of the tube, there's a high chance that it may come out or get dislodged. Preoperatively, one must do a fetal karyotype to rule out congenital anomalies and chordosynthesis to rule out infections. Both of these are absolute contraindications to any fetal interventions for hydrocephalus, and you have to select your candidates very, very rigidly. Advantages of fetal surgery is that it will prevent the white matter damage, that is the stage neuronal development. So it should have produce a better neurocognitive outcome. However, there's also there's chances of having decreased permanent shunt rate, decrease in multiloculated hydrocephalus. But the disadvantage is that cephalocentesis can cause infection, and the ventricular amniotic shunt is prone to migration, along with fetal morbidities and maternal morbidities. The neurocognitive outcome, though theoretically sounds well, actually is not so bright, as you can see in this comparison. In cases of isolated aqueductal stenosis treated in utero compared with neonatal shunting. So there's not much difference in the outcome, even if you treat early, unlike the cases of Chiari malformations or spinal dysplasia. Neonatal hydrocephalus are commonly due to post-germinal matrix hemorrhage, post-infective or congenital in nature. Our index case that I described previously went on to have a premature delivery at 36 weeks with a 1950-gram body weight. So these are her USGs at day 1 and day 3. And because of this intracranial bleed, she was developing hydrocephalus. As you know, germinal matrix hemorrhage occurs commonly due to a rupture of the periventricular blood vessels into the subependymal layers, commonly near the head of the caudate nucleus. And this blood obstructs CSF flow. Also, the proteins, the reactive glycase, the arachnoiditis also cause CSF obstruction. The maximum incidence occurs between day 1 to day 4. 12% will go on to develop hydrocephalus, and even some babies will go on to develop hydrocephalus in late infant or early childhood period. All of you know about the papillary grading of germinal matrix hemorrhage, where grade 1 is hemorrhage confined to a germinal matrix, grade 2 and 3 are interventricular extensions, and grade 4 there is associated parenchymal hemorrhage. The treatment option is to have a ventricular tap and external ventricular drainage or external ventricular access, or a ventricular access device. All three of these are prone to infections, and so the commonly used procedure nowadays are either the ventricular subclavial shunt. The VP shunt is possibly is one to be avoided in the neonatal period because of the complications of pressure necrosis of the valve of the thin skin of the child, along with CSF leak and abdominal end problems like associated necrotizing enterocolitis in a certain subset of the babies. Even if you put in and the problems of under drainage and over drainage, even if you put in a programmable valves, the valve profile is very large and it is subjected to skin erosion, and is very difficult to adjust the programmable valve in children. And large volumes of germinal matrix hemorrhage, there is an option of having a neuroendoscopic lavage. especially if there is a large clot and hydrocephalus, where we put in an endoscope and do the slow lavage with a warm lingual lactate with a pressure along with a pressure bag, along with a control aspiration of solid clots, plus minus installation of local TPA. This has shown to be reducing the shunt dependency, the risk of multiloculated hydrocephalus. However, the neurofunctional outcomes are not altered by neuroendoscopic lavage. So VSD shunts are the best of the both worlds. It is simple. It avoids over drainage and slippage, like in EVDs. It also minimizes infections associated with ventricular access device, allows CSF analysis, can be easily replaceable, and decreases permanent shunt rate. And that is what we practice in our day-to-day practice. This is an algorithm of post-intraventricular hemorrhage hydrocephalus in a neonate. We usually do a first VSG shunt and then follow up the child, see whether he or she is again developing hydrocephalus or the shunt is getting dislodged. In the first instance, if within 3 months, we generally replace the VSG shunt once, and then finally, if the hydrocephalus is persisting, we go for VP shunt. If there's a large volume of interventricular clot to start with, then there's an option of having a neuroendoscopic lavage. So our index case, after 1 year, underwent similar treatment, a VSG shunt on 5th day, and revision VSG at 1 month, ultimately a formal VP shunt at 4th month, and then she is now almost near normal with good neurocognitive outcomes. So the take-home messages are: the routine ultrasound must be part of the routine antenatal checkup, which unfortunately is not followed in our developing countries like ours. We have to differentiate the fetal ventriculomegaly with fetal hydrocephalus and counsel the parents in such a manner, whether it is a benign ventriculomegaly or it is a pathological hydrocephalus. If there's an hydrocephalus, we have to consult the obstetricians and plan for an early elective delivery and follow up the child with a postnatal serial ultrasound. And in germinal matrix hemorrhage or postnatal hydrocephalus in the neonatal period, it is safer to do a ventricular subgaleal shunt with or without a neuroendoscopic lavage. Thank you so much for your patient hearing and time. Thank you so much.
Thank you so much, Casio. So any question or comment from the audience or faculty?
So there is one question from the faculty. How do you perform a fetal ETV? What kind of endoscope do you use?
No. See, the fetal surgery is still not recognized in India, so I have not done any of these surgeries.
Jose, may I ask that for your neuroendoscope lavage, is there age limitation or the body weight limitation? Like if it's less than 1,000 grams, is okay for the lavage?
We usually target the lavage between, if it is around 1,500 grams, the children not less than that, and the babies are clinically stable sufficiently to be taken to the operation theater from the SNCU.
Okay. Any further question? If not, I think we will move to the second talk. So now we welcome Dr. Wittayanakorn to talk about treat hydrocephalus by shunt.
Okay, can you hear me?
Yes.
Okay, thank you, Sharon. My talk will merge on my Zoom camera. Can you see my slide now?
Yes.
Okay, let me start on this. So if you guys can can select on the top right corner that speaker wheel, then you can see me in a whole screen. Okay, so hi, it's Gong from Thailand. Hi again. And
but so you're not sharing your screen on.
No, I'm not sharing a screen because the talk will merge on my Zoom camera. So if you use the wheel,
This is modern way of presentation.
if you go to the top right corner and select the speaker wheel, then you can see me in a big screen.
Yes.
Yes.
Okay. Is that okay?
Yes.
Try something funny. Okay.
No,
So-
but as soon as someone else speaks, you're out of the big screen, by the way. So please, everybody,
Yeah. So
nobody speaks.
yeah. Thank you. Right. Let me start. This is my brief info that I was asked to put up. So my name is really long, so you can call me Kung for short. And well, nothing else that I should say. I done of most of my education in Thailand, and after the residency, I did a postgrad training in Kenya with Professor Albright, and very lucky enough to be part of the clinical fellowship program at the Royal Children's Hospital with my boss lady. And I also did some training with a flexible endoscope in Uganda. And now I'm working at the Children's Hospital in Bangkok, Queen Surrogate National Institute of Child Health. So my talk today is about shunt in hydrocephalus patients. And as you know that, because this is the special cycle of AAACPN masterclass, so I have only 10 minutes, so I won't be digging in the detail of hydrocephalus, and I would rather take you through the case and its complication. At the end, I will highlight 3 key messages to you, and I have no disclosure. All right. This is the boy presenting my service at 3 months of age with seizures and microcephaly. His head circumference has gone up 4 centimeters within a month, and it was crossing over the 97th percentile. I could not retrieve his first CT because it was done somewhere locally, but there was an evidence of thin IVH. So I did MRI, MRA, and MRV. Unfortunately, apart from huge ventricle, we couldn't see anything else. Also, there's no obstruction along the CSF pathway, as you can see in this picture. So in conclusion of his problem, I think this baby has got post-hemorrhagic hydrocephalus and epilepsy that need to be treated. He made it more challenging with right branchial fistula that I found after surgery. Thank God that it was not that close to our surgical site. At this point, I think no one can deny that he will require CSF diversion, and shunt seems to be the best option since there was no obstruction seen on the scan. So my first key message is the questions that should we shunt or not to shunt the patients, and I will clarify all the key cicator later. So I did shunt for him, and neurologist Dr. Keen also did operate for his seizures. So my second key message is just to highlight on the device and surgical technique. I think every country has their device limitation. For example, my country, Thailand, differential pressure valve is covered by the government. So it is always the first time. That's why I use ultra small medium pressure valve for him. You can see from the head chart that his head circumference was tracking well around 50th percentile after insertion, and things seems heading to the right directions until after 2.5 years from shunt insertions. I'm sorry. Okay. All right. I'm so sorry. It just doesn't go well. Let's return to the. Okay, I think we were here. After 2.5 years from shunt insertion, he developed some symptoms. Mom report that 3 to 4 days per week, he was really sick in the morning and spent 6 hours in bed with headache and vomiting. But he got up and played as normal in the afternoon. He got to admission from his vomiting, and we did a CT that had shown slit ventricle appearance, as you can see down here. So this is where I will highlight my third key message, which is about complications and monitoring. He got supportive care for a month. He had been having bad days more than good days. And I'm quite sure at this stage that I'm dealing with maybe slit ventricle syndrome. He underwent shunt revision, and as I suspected, he has a working shunt. So I changed the valve to OSV2. He underwent, he had made a quick recovery, and he had been well since. You can see on the head chart that his head circumference now is making progress up to 97 centile, but it was correlate well with its weight and height this time. Below, you can see those 4 scans that were taken in a different time point. The first is pre-op with a huge ventricle. The second was a year after insertion, and you can see ventricular size has reduced nicely. And the third was at the symptoms, and you can see the ventricle become very, very slit. And the fourth was taken 6 months after revision, and you can see the ventricle was re-expand. Now I will clarify 3 key points that I mentioned earlier. So when should we treat patients with shunt? I think many times you will get referral of patients with ventriculomegaly, but no other symptoms and signs to convince you enough that patients has hydrocephalus. So ventriculomegaly is not equal to hydrocephalus, and patient with only ventriculomegaly from whatever reason should not be shunted at all. I think before we shunt the patient, we should be able to identify etiology of that hydrocephalus, sign of increased intracranial pressure, and look thoroughly into their scan. Sometimes we need ICP monitoring to prove our diagnosis before we're proceeding to shunt. The second part is device and technique. Choosing the device, I think it's difficult because there are so many, but most of the time, not everyone can choose from all. As I mentioned before, that every country has limitation. So every device also had good and bad sides, so sometimes leading to common complication. So whatever we use, we should aware for their problems that might happen in the future. For example, we should avoid using full barium tube because in long term, it will be calcified along the shunt track. Not only the cosmetic problem, but leading to shunt fracture or even calcification in the brain. And you can't remove it during your revision. People always ask which one is the proper valve. I think there is no right answer to that, but I reckon that what they said is right. Choose the simple valve first and leave complex or programmable to those complex cases. Choice of valve is also limited in some countries, so we just have to use what we have and hope for the best. In terms of surgical techniques, I think the most important key is to prevent the infection. So we should use double non-powder glove. We should be careful on our sterile process in theater or even in central supply units. We should be very strict on our skin preparations and draping by using maybe traditional 3-PEP solutions and ioband drape. Antibiotic-wise, I think everybody will use IV prophylaxis, but there are also many ways of using antibiotics in the literature. For example, intraventricular injection, topical use, or mix it with the irrigation fluid, or even use antibiotic course device. But I think your choice depends on your experience, your institutes, and circumstance. Skin is also well known as a source of bacteria for shunt infection and also other complications. So to prevent them, we should make a decent skin flap with good pocket for valve, make a small burr hole and urotomy to prevent scissor leakage, high oxygen underneath the device because it might penetrate out from the baby's skin. Avoid cutting the steel tip to create sharp and raw surface. Again, it might penetrate to the jaw with your organ. Watertight gale closure, as you always do. Put early salt pressure dressing if required. In terms of prevent early occlusion, some tips and device would help. So proper length for both proximal and distal catheter is mandatory. Good position may achieved by blind insertion or using endoscopic or navigator guide in a difficult case. And to keep the catheter floating in the ventricle freely, right angle catheter or right angle clip would be very helpful in this instance. My final tip for surgical technique would be disposable is possible. If you can use disposable stuff for shunt procedures, please do, to avoid bacterial colonization in those re-sterile stuff. For example, shunt passer or a drape. Allow system connection as necessary to avoid shunt disconnection, and try to avoid complex shunts because it sometimes can come around and bite you later during the revision procedure. I think you all familiar with shunt complication that I listed here, and handle shunt procedure with care will reduce them but can't prevent them for 100%. So we need to keep an eye on our patients. We may see them for a few times during the first year after insertion, but if the shunt survives, see them every year is also necessary to keep tracking on the head circumference and their clinical, and follow the baseline imaging intermittently so we have some things to compare when they present with suspect symptoms of shunt malfunction. And I think this is all I have for my 10 minutes. Thank you.
Great. Great talk, Seng Nang. Any question from the audience or the faculty? There is a question from the chat. How can you replace the ventricle catheter and make sure new shunt will work well because of paucity of IV intraventricular CSF?
You can hear me? To be honest, I think everybody has this problem when you got the most shunt block. And it's very difficult to pull it out. As somebody used that stylet technique and put the cautery in and then try to stir it and then pull it out gently. But I don't think I had a bad experience with that as well, that when you pull it out, it's have a massive ventricular bleeding and blah blah blah. So I think I review lots of literature, and I think the best recommendation, if you really need to remove that catheter, you're supposed to go in with the endoscope and try to free it up before you pull it out. But in a limit facility kind of hospital, you just don't put, you may have to put another one in, next to it, or maybe the other side, and leave that catheter that's stuck there, maybe something like that. Or if you can't really deal with it, just put EVD on a different side. Maybe if the ventricle's really slit, you may use the navigator to help you. Because full track, it's, the complications that is really nasty.
Yeah, but for the sleep ventricle, the CSF was very is small. So yeah. How will you work well with the paucity of intraventricular CSF gush out?
So if I see the ventricles really slit, it actually happened for me happened to me a couple of weeks ago, that the ventricle really slit, the proximal end was occluded, and there was a lot of bleeding in the ventricle. So I went back in with the navigator, registrations, and put the EVD using under navigator assist just to drain the CSF, and then try to plan to put a new shunt later on when the CSF clear up. So I think that if we think it's really slit, you need to have a plan B, and navigator assist would help.
Yeah.
May I question about your cases? It's interesting. You change it to the shunt valve, to the OSB, and it works, right?
It's worked very well.
Yeah. If I understand correctly, your operative finding was shunt is still open. The CSF is still coming out, but
Yeah.
ICP was high, right? Is that right?
Yeah, it's very high. The CSF was pouring out
So-
when I disconnect the proximal
Yeah.
one.
So is that the sleep ventricle syndrome or the partial obstruction of shunt catheter?
I think it's a slit ventricle syndrome because he has, like good time and bad time during the day, and headache and vomiting not happen every day. So it's actually, the clinical that really fluctuated for the whole month. I was thinking as well that maybe partial obstruction. At first, I talked to the family, and I think that I will put the ICP monitor in, but the family thinks that it's going to be another operation and another operation. So they should that I should go explore the shunt, and if I'll actually act accordingly to what I've found during the surgery.
Okay.
But
I think it's both.
but in terms of slit ventricle syndrome, I prefer to use OSV to correct it rather than programmable valve, because I think it's more difficult in terms of adjusting the valve.
Yeah, but by definitions, sleep ventricle syndrome, interventricular pressure probably not high, if I understand correctly. So if you see that is not truly sleep ventricle syndrome, but sleep ventricle with obstruction of ventricular catheter. In those cases, we measure some cranial expansion, I think. And it's all right. You can change it to and then change the catheter and the valve to the programmable. It works, but I did some cases too, like you. And then we have some confusion about in the sleep ventricle syndromes. So it's not
I
easy.
think it's hard to prove. Yeah.
Okay.
I think it has to prove. Yep.
Okay, my last question to Nan is that what's the length of the peritoneal catheter you suggest to put inside the peritoneal cavity? How long you suggest? Because too short is when the baby grown up, it will need another surgery, but too long will increase the complication.
Yeah. So basically, I remember that when we do a conference, like a case discussion earlier, people said that you're supposed to put all the length in, so just do not cut it because it was designed that way. But in my practice, I will pretty much put in about 30-40 centimeter within the tummy. Okay, because I don't think people grow by their leg. They get taller because of their leg rather than their body. So their bodies didn't grow much. So 30-40 centimeters is long enough. And even when they grow up to their adulthood, pretty much.
Yeah. Okay. Thank you, Nan. So it's going to my session. So I'm going to share my screen. So now I'm Robert Sing Hong Chen from Taipei Veterans General Hospital. I'm going to talk about the ETV part for the treatment of hydrocephalus. So I'm come from Taipei, Taiwan. I have my fellowship in Salt Lake City, Utah, Paris, France, and also Rome, Italy. And today, I think also the pathogenesis of hydrocephalus is become more and more complicated, like the new concept of lymphatic system. But still, I have to emphasize that the best shunt surgery for hydrocephalus is still no shunt. So in 1970s, Hopkins invented a new generation of neuroscope. So now we Taipei Veterans General Hospital performed our first ETV in 1995. Until now, we have do more than 500 ETV in our institute. Continue with my mentor, Professor Taidong Wang. I think currently I totally agree. Everyone should know that ETV success score is I think the etiology and the age is the most important factor to evaluate your successful rate. So I think for the children older than 6 months of age, and if the etiology is aqueductal stenosis or tumor hydrocephalus caused by obstruction is the best candidate for ETV. But if the patient is younger than 6 months of age and the etiology is post-infectious hydrocephalus, I think is not a good candidate for ETV. So then I will show how we do ETV in our hand. So the first case is 15 months ago with a progressive macrocephaly and also sustained a big anterior fontanelle with tense pressure of his head. And so it's maybe a little bit aqueduct stenosis and forced ventricle outlet obstruction. So we perform the ETV. So we regularly perform from the cochlear point to the right ventricle, usually from right side because it's a good way. Then you can see the foramen Monroe and the coronary plexus and go into the third ventricle. Then in the third ventricle floor, you have to make sure the mammary bodies and the infundibulary recess. And in this triangle, you put the hole in the center of tuberous cinerarian and avoid to damage the basilar artery. So and in the first 10 years, we use a reusable basket device. It's usually used by the urologist for the ureter stone, and it is a good device that you can perform the ETV because it's reusable. So we almost never use for the floor, and we just blunt puncture with this device and open the basket and hold it for seconds to keep the hole open, and hold it for like 1 minute and to stop bleeding. And you can see that the ETV was performed successfully. And if and it's important to notice that if the lytic membrane underneath the tuberous cinerarian is not open, you have to do it again. Okay, so and in recent 10 years, like this case, this preterm baby with a progressive ventriculomegaly, and so and the head circumference was become bigger and bigger. So after 5 months of the after birth, we decided to perform the ETV, and now in the recent 10 years, we prefer to use the 3 French Fogarty catheter for the ETV because you can use this balloon to keep the hole and stop the bleeding. And because this is a post-hemorrhage hydrocephalus, the first thing you have to open the right side Monroe. So this you always follow the coronary plexus to the foramen Monroe and find out and because this case was the Monroe was obstructed by the membrane, the first thing you have to do is to open the Monroe first, and this is the aqueduct. Then you, like the previous case, you find out the parietal mammary bodies and infundibulary recess, and puncture the center of this triangle of tuberous cinerarian with this Fogarty catheter with the balloon opening. And usually I open the balloon for 2 to 3 minutes to stop the bleeding and also maintain the hole, the size of the hole. And this is very common. The failure of the ETV is because of the tense lytic membrane. So like this case, you have to open the lytic membrane by the second puncture of this Fogarty catheter. And so for this procedure, you have to watch out the abducens nerve and oculomotor nerve, and also be careful. You have to parallel to the basilar artery to keep the no injury to any vascular inside this prepunding system. So so this is a very smooth surgery, and I have the recommendation that actually the warm lung ringer is the best way to stop the bleeding. So now for the almost every cases, we don't have to, the patient don't have to stay in the ICU to monitoring, and also they can discharge in the next day after the ETV. And I also have to emphasize that also ETV is a very good surgery for hydrocephalus, but lead rapid deterioration is a very important complication. So because of the whole of the ETV could be closed by spontaneously, but usually after 5 years, the closure will be become very rare, but it's still possible. So you have to remind the parents of the patient that the possible that rapid deterioration of the ETV. And I think everyone know that Professor Wolf performed ETV and CPC for the post-infectious hydrocephalus, and it's a very important procedure for everyone to develop this. And also the now the endoscope, neuroendoscope surgery was a trend from the rigid endoscope to the flexible endoscope. So this is when I went to Boston to see how they perform ETV and CBC with this storage flexible endoscope. And I think everyone know that for ETV or ETV plus CBC, that many times that you can see the ventricle is still big, but it's nothing related to the outcome, because the brain parenchyma was actually the same in the shunted group and the ETV group. So the cognitive function and the development of both group is the same. And I think for the ETV for adult, there is also a good candidate if the etiology is aqueduct stenosis of a tumor obstruction, and even if it's a communicating hydrocephalus, ETV is still effective in the 40 to 60% of the cases. And if if the patient received the VP shunt initially, but the etiology is aqueduct or tumor obstruction, you can change the VP shunt to ETV. The transformation rate is very high. And also for the long-term EVD, you can also try the ETV. The success rate is almost 80%. And like I mentioned previously, if the ETV sustained for 5 years, the failure rate was very rare. So I have to emphasize that the complication rate for ETV in a experienced hand is actually very low. Currently, in our series from Professor Tadwan to me, the complication is almost zero. We have zero infection case, and also we never injure the hypothalamus or the the pituitary gland or the major vascular. But you have to always watch out and be very careful and reduce your complication rate. And when you fenestrate in the cervical floor, the transient bradycardia is quite common, but it's usually transient. So here is my talk. Thank you very much. Any question from the audience?
Robert, can I ask you a question?
Yeah.
I'm Suresh from Mumbai.
Hi.
Okay, hi. A very good presentation on ETV, and your results were superb. Very nice. Just one question. One of the failure of ETV in neonates and infants is the CSF absorption defect. When the CSF absorption system is not fully developed. So before doing the ETV in neonates, do you really evaluate the children by some investigation or some test to see the CSF absorption is good? Do you do that?
No. Any suggestion from you?
No, no.
Because I personally, I just explained to the parents that our complication rate and is very low. But for the neonate, for the infant younger than 6 months of age, the success rate is very low, like 30% or 20%. So, but the complication rate is very low. So, if they agree, it's still worth to try ETV to prevent permanent shunt. But there's still a very high percentage of these post-hemorrhage hydrocephalus to become shunt to put the shunt if the age is younger than 6 months of age. Yeah.
Okay. All right.
Or any suggestion from the audience? Any experience?
Yeah, but sorry, there's a question though from the audience, which I think is relevant. After an ETV, do you place an EVD in every case, or when would you decide to do that?
Yeah, in the first 10 years experience, we put EVD for monitoring and also put the patient in the ICU. But now, like I mentioned, with the 3 French forgotten caster, with the balloon to stop the bleeding, and also the warm lactic ringer to irrigation to stop the bleeding, we now don't use any EVD, and the patient don't have to monitor in the ICU, in the PQ. So we have abandoned EVD and PQ monitoring for more than 10 years, and no problem at all.
Robert, can I
go ahead. Can you?
Yeah, thank you so much. Thank you. I enjoyed your the good lecture, Robert. Can you hear me?
Yes.
Okay. I'm always wondering about to avoid the cold plexus coagulations, the complication. I mean that, as you know, the cold plexus is not a degenerated organ. It has a function. For example, you know, for child and neurotrophic factor secretion or the immune surveillance. How do you think about the complication with CPC?
Yeah, so that's why I go Boston to see Professor Wolf to perform the surgery and his patient myself. I think currently is many patient follow up more than 5 years. So I think in their hands and their data is still a good option for the infants, like especially for the post-infectious hydrocephalus, because I think ETV is not a good candidate for post-infectious hydrocephalus. But I think I will not do AV cases of ETV plus CPC. Yeah, I think we still have a indication and criteria for the for that. Yeah,
I think we have to collaborate to the neuroscientist for this program.
Yeah,
I think so.
Yes, sure,
Thank
sure.
you.
Agree,
Thank you very
totally.
much. Okay.
So, Professor Ra, any question? No?
Oh, yeah. So once you have
One
done
last question,
the
sorry.
ETV, I agree with you, like a Lilikis membrane, one of the big things you have to penetrate. But after you're done, how long can you wait? Like, you decided to put shunt. How long you wait for to decide is it a fail or success? How long?
So like I say that usually the etiology is very important. So usually my first choice is obstructive hydrocephalus. So for the obstructive hydrocephalus, I think it will be 1 week. It's long enough to observe the successful rate for the ETV. And some of I think 50%, more than 50% of my patients will come from not from Taipei City. They come from the other part of my country. So for that come from not far away, that I will perform image study before his or her discharge to make
when
sure
you decide
the ETV
sorry,
is
yeah. Okay, so 1 week. So when you decide to this is successful or the fail, so what is important clinical the finding you determine which is successful?
In my experience, that I have several cases. I perform ETV and it's successful for like 1 or 2 weeks or even 1 month. But then again, so but closure again very soon. So for this, I have several cases like this. I will maximum I will give the patient three times of the chance to do the ETV. If the stomy was closure more than 2 times, then I will shunt.
So my question was like a head circumference or a CT or MRI. So which method is your like preferred to determine
always MRI.
Is it successful?
MRI with heavy T2. With heavy T2
you just doing the MRI scan.
Yes. I think yeah. And you have to do the heavy T2 thin cut image, and you have to make sure that the pre-pounding system is clear. I think the arachnoiditis in the pre-pounding system is one of the most important risk factor for the ETV failure.
Okay. Thank you.
Okay, because of time, I think we have to move to the next talk. So the next talk will be by Professor Mengfei Guo to talk about arachnoid cyst surgery. Professor Guo, may you share your screen?
Yeah, I've opened it. I've shared it. Can you see it?
Not yet.
I've tried that before. I don't know why.
We have seen your presentation, Mengfei, earlier.
Right.
It was coming on quite well.
I didn't touch anything.
You're unable to
Dinesh, are you able to help?
Dinesh?
Or you may open your mailbox. I have sent the slide to you.
Yes, let me see if Dinesh is around. Dinesh?
Dinesh is around?
Yes, sir.
Yeah, just see why she's not been able to share the screen. Oh, there she is.
Oh, yes, we see you.
You got it?
Professor Guo, we see your screen. Yes.
Okay. Is it a full screen slide?
Yes.
Okay, you got it. I'm Mengfei Guo from National Taiwan University Hospital. And today my talk is about the intracranial arachnoid cyst.
Very nice drawing.
Yeah, very nice.
I love it too. Yeah, a true arachnoid cyst should contain both the external and internal walls, and the walls composed of arachnoid cells and collagen, and the content of it is CSF-like. And the typical location of the intracranial arachnoid cyst may be located at supratentorial, tentorial, infratentorial, and other location. And the most common one is the supratentorial, the middle fossa. And the quadrigeminal plates accounts for 10%, and the infratentorial one accounts for 10 to about 23%. So the left side is the drawing from the website. I think it's very look very real to what we've seen during surgery. And the natural history of arachnoid cysts are variable and unpredictable. It may be stable or may enlarged quickly or slow, or sometimes it may spontaneously shrinking or even complete resolution, like the upper right case. It was diagnosed to have an arachnoid cyst before he was born. And after 3 years of observation, the arachnoid cyst shrink spontaneously. And the arynoid cyst might rupture, especially after my concussion, direct head impact. But we have to know that most of the patients do not need a surgical intervention. In my cohort study about 20 years ago in my hospital, the less than 10% of the patients require surgery. And like the right lower column of this patient, he's a 20 years old boy, and he was incidentally found to have a huge retrocerebellar arynoid cyst, and without symptoms, he was observed and very well for at least 5 years. And the surgical treatment options for arynoid cyst are listed below. It may be drained or excised, but these two techniques should be used very rarely. Actually, I never use this. And the two most common methods are fenestration and CP shunt. And there are other little surgery, but today I will focus at cyst fenestration and CP shunt technique. So the operation for arynoid cyst includes a lot of little methods, and the fenestration and CP shunt are the most commonly used. Dr. Raimondi has stated that the success rate for permanent obliteration of the cyst and cerebral re-expansion is not the indication to operate upon the patients. So he thought that we should have a definite clinical indications. Otherwise, we should observe the patients. I absolutely agree with this philosophy. And so again, I must emphasize that most cases require no surgical interventions. But I think that some patients has the indication for operation, such as hydrocephalus or midline shift, or with neurological deficit, or a large cyst. The size is larger than 5 centimeter in diameter. And if the patient is young enough with the potential of brain expansion, with this strict indication, well, we might need to operate upon this patient. But in my opinion, if we decide to operate upon the cyst, I think I will try to obliterate the cyst as much as possible. Maybe it will take slowly and takes years, but we may trade off. We may use time to get back the space, and the cerebral re-expansion might be possible. So if I select the patient very strictly, then once I operate upon the patients, I would like to have an obliteration as much as possible and without complication, and have the cerebral re-expansion. And the following slides, I would like to share with you some cases to demonstrate the shunt and fenestration. And this is a 5-year-old boy. He suffered from nystagmus and vomiting in the morning off and on for 3 years. And MRI shows that here is a metatarsal arynoid cyst. And the patient is 5 years old. So he still had the potential of brain growth. But then at that time, we choose CP shunt. And at that time, we don't have a programmable valve. So I use the usual VP shunt for him. And to shunt a patient, it's cautious. We have to see after surgery the direction of brain expansion. Which direction? For example, the middle fossa, the brain will expand toward the spinal ridge, and downward toward the temporal fossa. So we should imagine the last space after the brain expansion. It should be here and here. So before surgery, I would imagine if I put in a shunt, what will the space that will still there at the last moments. So I will put the shunt tip here. And so this is the case. I put in the shunt tip here, and 6 months later, the brain expanded very well, and the shunt position is still good, not occluded. So the ideal location of the cystic catheter tips for a quadrigeminal plate cyst, I will aim at here, the final, the quadrigeminal cistern. And for suprasellar preponderance, area will be the tip of the location of the tip. And for retrocerebellar one, the tip should be located here. That might prevent occlusion of the cystic catheter. And for this girl, I put, again, it's before the era of programmable valve. So I put in a shunt here. And you can see that after 3 months, the brain expanded very well. But please look at this picture. This picture was taken about 1 week after the surgery. The coronal suture ridge become prominent. So I think definitely the patient had over drainage, though she was well at the time. And in the later 5 years, she had mild headache off and on. That indicate a shunt dependency. And I and she were fortunate that her symptoms spontaneously resolved. But again, here, I would like to mention, I would like to emphasize that if we can use a programmable valve, that would be better to prevent a shunt over drainage in CP shunt insertion. So to avoid over drainage, we may avoid a shunt dependency and use programmable valve and increase the shunt pressure setting according to the patient's age and cranial condition and imaging findings. And if we are doing shunt surgery, it has to be a bloodless surgery from the beginning to the end. This case, just a little bleeding here that might cause septation in the cyst. That might cause malfunction or not fully function of the tip, the shunt tip. And the other surgical tips for a CP shunt insertion is to prevent subgaleal CSF accumulation, we open the dura as small as possible, just enough for the passage of the catheter. The second, to prevent subdural collection, that's acute overdrainage. We should prevent excessive loss of CSF and to prevent the detachment of the outer wall of the arytenoid cyst from the dura. And once we open the arytenoid, quickly insert the cystic catheter into the cyst, and that may prevent collapse of the cyst. And about the fenestration, I will use the middle fossa case to demonstrate this again. This is the 10-month-old boy. He was found to have progressive enlargement of the arytenoid cyst after birth. And we use a small craniotomy to open the dura. And you can see the pressure is high. The CSF gush out from the small opening of the arytenoid. And please note that we have to have the arytenoid membrane excise and reflect the arytenoid membrane and to attach onto the dura and not to make subdural space appear. And after that, we start to fenestrate here. In this case, I use microscopic to fenestrate. So here, and then go to the frontal lobe to fenestrate. And in this case, it may be done with endoscopic fenestration because the adenoid here is rather big, so you can do it with endoscopic too. And here is the case when he was 6 months old, 10 months, enlarged. So I do fenestration, and 4 months later, here's a little subdural collection, and wait for another 4 months. He was cured. So the surgical tips of microscopic fenestration include, again, a bloodless surgery and the reflection of the outer cystic wall of the aryenoid membrane onto the dura to avoid the appearance of subdural space, and fenestrate to the cistern or prominent subarachnoid space with endoscope or microscopic technique, and not the margin of the cyst. And convexity aryenoid cyst and fenestration, in this case, here is the prominent subarachnoid space. So we may approach this case with a small craniotomy and fenestrate here. In this case, endoscopic, like a Fogarty balloon, might be too deep for the dissection to the opening here. So in this case, I would like to use microscopic fenestration. And in some case related to the ventricle, we may use endoscopic fenestration, one polar fenestration, or some case need another bipolar fenestration into the prepontine cistern. And here's the result. So the take-home message is conservative treatment may be the best policy in most patients with aryenoid cyst. The best surgical method is still controversial. A bloodless surgery is the key to less complication. And to avoid the shunt occlusion or dependency after shunt surgery, we should choose the best position of the shunt tip. And we might use programmable valve to have a higher pressure setting according to the patient's age and the patient's needs. And no matter we use microscope or endoscope fenestration, we may fenestrate into the subarachnoid space or cistern respectively. Again, still without bleeding. So thank you very much, and please save the days for AAACPN in the following December, and see you in Yokohama, Japan. Thank you.
Thank you, Professor Guo. It's a great talk and a very good take-home messages. So any question or comment from the audience?
Can I just ask, sorry?
No, please
Can
go.
I ask a question?
Yeah, please.
Get to Megvai, how do you attach the arachnoid to the dura so that it stays there? When you say you reflect it to prevent subdurals, but how do you maintain it?
Yeah. When I open the dura, then I will design the aryenoid and then reflect it, and I use a Surgicel. During the surgery, any kind of or cottonoid, you can keep the aryenoid attached to the dura, right? And after you finish the fenestration, when you repair the dura, you can suture the aryenoid at the same time so keep them together. Thank you for your question.
So, Dr. Puo, I had a question.
Pardon?
I was not very clear. How do you decide when you are going to do shunt or when you are going to do fenestration upfront? First choice.
Right. Actually, about 20 years ago, I used a lot of shunt, and the result was excellent, good. But as Robert has said, that shunt dependency is a problem, and after I use programmable shunt, the shunt dependency become less. And in recent 10 years, I start to try fenestration. But the skill I have talked about today I think that's the base I use to do the fenestration. If it's not followed good enough, sometimes I think it's not that good. So it's like a paradigm. But I think no matter you choose shunt or you choose fenestration, you have to have, if you do a shunting, please choose programmable, and you have to know how to tune up the pressure setting to avoid shunt dependency. Though the patient has shunt, but the patient won't have shunt dependency symptoms. If you don't have a good shunt, please try fenestration. And you may use endoscope for the one with large communication with the system. You may use endoscopic fenestration. And for a superficial aryanoid cyst, you just do an operation microscopic to fenestrate it into the subarachnoid space. So I think in the world, every country has different facility. So you may choose shunt or fenestration, but without complication, I think is the most
Okay, I think it's the network. So because of the time, I think we have to move to the case discussion part. So Professor Shira, may you show your first case discussion?
Can you unshare your screen, Dr.
Go of this surgery? Yeah.
I have some more questions, but we can ask later.
Yeah. So I think the case discussion will be started by Professor Sankara.
Okay. Right, I'll just share my screen.
Not yet.
Can you see?
Yes.
Robert?
Yes.
Can you see my slide?
Yes, yes, yes.
Slide?
Yes. Happy
All
New
right.
Year.
Thank you for giving me to share my experience and one interesting case of just a second. Okay, you can see this slide here.
Yes.
Robert. Okay, so in case of complex and discuss complex hydrocephalus. So this is a 12-year-old girl whom we saw back who onset, later on associated with vomiting, and she also had urinary and had no or seizures. So we took a complete history. When she was 2 months old, she went to the pediatrician with enlarged head and bulging fontanelle, and the signs of raised intracranial pressure were documented by the pediatrician. And then she was seen, who ordered CT scan and MRI scan, which obviously showed an obstructive hydro.
Hello, Professor Senka. The internet was broken. Okay.
You're muted, Suresh. No. Dinesh, can we unmute Suresh?
Right.
We just need you to unmute him. Robert, shall we move on while Suresh is sorting out his
Yeah, I think we can go to the next presenter.
yeah, why don't we do
Okay.
that in the interest of time?
Okay. So, Kaushik, may you be the next?
Robert,
Oh, okay.
can you
Okay.
hear me?
Yes, yes, now we can hear you.
Okay,
Yes,
there
now.
was something wrong with my connection, so now I'm okay. All right, can you see this right now?
Yes, 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 we
Okay,
can.
fine. So uh, uh,
Mute again.
next 10 years, she had
I think the
Okay.
moment he shares his slides, his bandwidth drops.
I think bandwidth is low, Suresh. You may not. What you can do is you can switch off your video and just present. You keep your slides on, but you can switch off your video.
video. My speaker is on.
So keep that way and share slides if you can.
Okay. That's
Yeah,
better.
it will work this way. Yeah.
Okay, I'll keep my video off in that case. So, in next 10 years, she had multiple shunt problems, and the shunt was revised 5 to 6 times. Once she had also developed meningitis and ventriculitis, and following that, she lost her vision. That was about 8 years back. But except that, she had generally good recovery, and she started going to special school and good learning abilities, motor functions were good. So this time when she presented to us, she had four ventricular peritoneal shunts inserted. She was conscious but sleepy. She was totally blind in both the eyes. Ocular movements were normal. She had horizontal nystagmus and unsteady gait, but otherwise there was no neurological deficits. And this is her X-ray skull. At that time, as you can see, there are 4 or 5 ventricular catheters present, and this was the CT scan when she presented to us, which clearly showing multiloculated hydrocephalus. There are multiple ventricular catheters, and there doesn't seem to be any connection with the right-sided ventricles with the left-sided ventricular system. This is her MRI scan, which again shows multiple intraventricular catheters and various number of septi dividing the right lateral ventricle as well as the left lateral ventricle, and the communication between the left and right lateral ventricle and the third ventricle were completely obliterated. The fourth ventricle was enlarged as an isolated fourth ventricle, and there seems to be some occlusion of the aqueduct in this view. So now we thought we are dealing with a clear-cut case of multiseptate or multiloculated hydrocephalus. So we plan to manage this case with these endoscopic procedures. And what we thought that we probably do the ETV first, the first procedure, because we could see the right foramen Monro wide enough to be eligible for the ETV. We then also thought that after ETV, probably we will do the intraventricular fenestration on the right side and do the septostomy on the right side, and then move on to the left side and also do the intraventricular fenestration as well as septostomy from the left lateral ventricle. And then, if possible, we'll take a look at the aqueduct and see if we can do the aqueductoplasty in order to maintain or create a good communication between all three ventricles. Then, if everything goes well, we'll remove all the malfunctioning shunts and probably put a temporary ventricular access device in one of the ventricles, or maybe a fresh ventriculoperitoneal shunt in one of the lateral ventricles. So this is how we plan. We first did the right frontal burr hole and approach the right lateral ventricle and the foramina. To our surprise, the foramen was right-sided foramen Monro was wide enough, and we were able to introduce the ventricular scope into the third ventricle. And although the margins and the walls of the lateral ventricle as well as the third ventricle were quite stiff and firm in nature, but it was possible to identify the floor of the third ventricle and do the fenestration and do a third ventriculostomy inside. And this you can see now the CSF flow through the stomy going into the basal cistern, and we also looked at the basal cisterns and the pre-pontine cistern and found that it is patent. So we came out and then we did the septostomy from right to left ventricle, and after that we did some fenestration in the right lateral ventricle, and then we made a left frontal burr hole and did the same kind of procedure in the left side fenestration. As you can see, as we went into the left lateral ventricle, we found a number of septi within the ventricular cavity, dividing the ventricular cavity into many small pockets. So we continued to do the fenestration as we came across any septi, and we opened all these septies and tried to communicate all those small loculi and tried to make one large ventricular cavity on the left side as well. And then we did the septostomy from the left side to the right side, and this is the septostomy. After doing that, this is another video showing multiple fenestrations on the left side, and at the end you can see there are lots of fenestrations in the left lateral ventricle. And then we move through the left lateral ventricle towards the aqueduct. And as you can see, this is the left lateral ventricle, and this is the aqueduct, which is completely obliterated by the presence of a large ependymal cyst, which is completely occluding the aqueduct. We thought this is probably occluding the aqueduct, and we tried to decompress the cyst, and then we slowly punctured it, and then using the piecemeal technique, we removed this cyst, and then we found that the CSF flow was good through the ventricle aqueduct. So then at this point, we thought that we have done enough of communication between all the three ventricles and opened up the aqueduct so that now all the four ventricles are in communication. So then we removed the all malfunctioning shunt and put a fresh right-sided ventriculoperitoneal shunt and made sure that it working well into the peritoneal cavity. However, within a week's time, we realized that the child is generally improved, but her fourth ventricle is still dilated and probably not in well communication with the rest of the ventricular system. And then she continued to have occipital headaches, and her imbalance and ataxic gait did not improve. So we thought probably we have to do the aqueductoplasty from the suboccipital route. So this we did here, including the suboccipital microscopic approach. The fourth ventricle was open, and this is the aqueduct which looked open. And then we put the fine catheter into it and punctured the septa, which was found within the cavity of the aqueduct, lumen of the aqueduct, and then we put the Fogarty catheter, 2-number Fogarty catheter, and just inflated it gently, keeping a close watch on her vitals. And we found that the aqueductoplasty has been done from the suboccipital route as well. And we found a good flow of CSF towards the end. So at this point, we thought probably everything has been in communication now. Post-operatively, she recovered, she improved, all her headaches relieved, vomiting stopped, her gait unsteadiness became better. She could walk and became independent as pre-operatively. And these are the post-operative CT scan showing a reasonably good communication, and the ventricular system are slowly subsiding and coming back to normal level. The brain is completely decompressed. The cerebellum and the posterior fossa also looked quite decompressed, and she has a very well functioning right-sided PP shunt. So using the endoscopic approach, we managed to manage this girl quite well, and she is at a regular follow-up, and she is doing quite well. She did not require any other procedure after that 2 years ago. Take-home message is that the multiloculated hydrocephalus is a complex disease in which no single treatment has clearly shown or proven to be the ideal. Neuroendoscopy remains the first line of treatment in such cases. The goal of the surgery is to restore communication between isolated intraventricular compartments in order to avoid shunt or implant a single simple shunt to drain one of the ventricular cavity. The objective of treatment of multiloculated hydrocephalus, however, should be to reduce the number of surgical procedures. And considering the complexity of the disease, we must evaluate these patients individually, and no procedure proposed by the literature or any previous experience should be ruled out completely, because each and every procedure may work in that individual patient. These are the take-home messages, and I stop here and I take some questions and let us discuss this case. So Robert, back to you.
Thank you. Very wonderful case presentation. And so any question or comment from the audience?
Les? Thank you.
Yes, Kenichi.
Yeah. It's a wonderful operation. Thank you. Congratulations. So I agree with your opinion that the real goal of the treatment of the complex multi-located hydrocephalus is the simplification of the shunt. But as you know, that we have to remove the shunt, and the removal of the shunt means that induce sometimes the hemorrhage because the tip of the catheter is connected to some connective tissues or the choroid plexus. Do you have some tips to avoid hemorrhage when you remove the shunt?
Yes, actually, in this particular patients and few more patients, when the endoscope is in the lateral ventricle, you can use the coagulation method, the bipolar coagulation method. So you first identify that shunt, and invariably it is embedded either in the ventricular wall or in the choroid plexus. So if it is safe, you have to just coagulate the entire length of the ventricular catheter, which is embedded in, and then try and put a stellate into the ventricular cavity and gently rotate, keeping a close eye if this is causing any kind of hemorrhage or any kind of pulling of the tissue or something. If that is happening, and with repeated attempts, if you think it is not going to come out, I would leave that catheter inside and not try and pull it out. But in a simple way, if it is coming out and if you can dislodge it from the ependymal wall or from the choroid plexus by using the coagulation technique, I would try and take it out as much as possible.
Yeah, thank you, Suresh. My technique is the same as you.
Same.
Thank you very much.
Thank you. Thanks.
Okay, great. So if no further question, Kaushik, will you show your case?
Yeah, I will show a short case. Just allow me to share my screen.
Thank you.
So this is a 19-day-old neonate who presented with a swelling in the left temporal region with a slightly bulge and clear fontanelle, not very tight. And she is a third child born in a remote location with a midwife-assisted delivery. And also mildly lethargic with a head circumference of around 36 centimeters, but there was no focal deficit. The idea of presentation today is to show you the scans. And I will go through the scans so that you can all see. This is the first image.
Mm-hmm.
Yeah, T2. Slightly enlarged view.
Mm-hmm.
This sagittal. And I will stop the coronal. So I will stop here and ask for the diagnosis from the esteemed audience. I'll again go through the images one by one. Possible diagnosis, what do you think?
It looks like the kid had an intrauterine hemorrhage affecting the left hemisphere and also, subdural. But I think over time, blood has broken down
and organized into clots with membranes, as they occur in elderly subdural hematomas.
Yeah, I mean, something like that. The fluid looks much whiter. I mean, more watery than bloody.
Yeah, and the densities are different in different zones. Here, the multi-compartmental and the density. Any other thoughts? And
infection.
So there is no history of any infections, and not maternal. Actually, the mother was not screened, but overtly that there was no history of any infections in the mother. And after the delivery, there was absolutely the child is, except that bulging of the temporal bone, temporal region, it was afebrile and the counts were normal. The coagulation profile done was normal, both the BTCT and the prothrombin time and the APTTs are normal. So I also thought it is a calcified subdural, multiloculated subdural hematoma due to a birth trauma. And this is aspirate after the operation theater, which shows only blood in various stages. So it is a case of neonatal birth trauma presenting with birth injuries. As you know, in birth trauma, especially in assisted deliveries done in remote locations, midwife assisted deliveries, especially if the babies are coming out in a breech position. It is the first child with a tight pelvis, and the child is the weight of the child is big, or there is an occult coagulopathy. There are chances of having tentorial tear. Usually, the literature describes the falcotentorial junction. There is a venous rupture, so there's hemorrhages mainly in the posterior fossa, then extending to the hemispheres, and it may be associated with subarachnoid hemorrhage or retinal hemorrhage. I could not test the retina in this child. There are 4 types of neonatal subdural hematomas. One is a type 1, which is localized around the posterior interhemispheric fissures. And type 2, where the extension, this posterior interhemispheric fissure subdural extends to the convexity. In the type 3, there is an extension to only the posterior fossa, that is in the infratentorial compartment. And type 4, where there is associated with large ICH. And naturally, the treatment is like any other subdural hematomas. And it is what I've studied in the literature, that the babies who are subjected to craniotomies and clot removal where most of them went on to develop hydrocephalus, necessitating formal VP shunt. Subduroperitoneal shunts are described in neonates in very few cases. In this child, we did a craniotomy and evacuated the blood clot. There was multiloculated membrane-like structures like you see in adult subdurals. We evacuated the blood clot, left behind the inner membrane, and decompressed as much as you could. The child had intractable seizures afterwards, and she has now recovered, but she has a residual left-sided hemiparesis and a small infarct, right-sided hemiparesis and a small infarct, possible due to surgical manipulation. So this is my case, and I'll stop with the screen sharing and join you for this.
Just check, do babies in India get the vitamin K shot as soon as they're delivered, or is that something that is not? Because sometimes, some of these children, we've seen some cases where they're all vitamin K deficient, they have bleeding, intracranial bleeding as well, and whether this could have been one of this.
We have not tested for vitamin K, but once in our NICUs, they were replaced. Vitamin K are being given as a routine.
That infarct which you said, Kaushik, can I have a look at that picture again? Does it look like an arterial or a venous infarct?
No, sorry. That is in post-operative scans. I don't have the post-operative scan now. They've taken away the scans.
So sometimes while trying to do a craniotomy, one of the problems which you face is there is a venous occlusion by handling, and you can get a venous infarct.
That's what I suspect also. Manipulation of inner membrane has led to some venous damage.
Oh, very interesting case. Thanks for the information and messages.
Yeah, we don't see neonatal subdural hematomas very often. It's common in children, but not in neonates.
Okay. Wow. Okay, because of time,
the child was, can I ask, the child was 19 days old. When you look at the blood, I guess it's much redder, so I think it's more recent than the usual brown color machine oil type fluid that we see. So this probably is more related to the delivery than to, because I thought looking at it, could that be intrauterine? But
yeah, right. I get your point. The blood was of different ages. The part of it is like fresh blood like that, and the other parts were like blackish and to see in subdural yellowish fluid or something. This was a very nasty looking, but there was no infection. We sent the valve for culture, And we sent also the fluid for culture, and there was no growth anywhere.
Yeah, that fresh, the blood definitely looked fresh. It wasn't old blood.
There were sections where fresh and fresh bleeding. There are different densities, even in the scan. There were different densities of blood at different points. However, we have not done a detailed coagulation testing like factor 5 and so on. This we could not do.
Okay. So, Nan, will you want to share case for discussion? Please.
Yep, sure. Can you hear me?
Yes.
So this is my case. This is the boy present to me when he is at 17 months old. It's like a walking into my clinic. So the local doctor that's treat him prior me said that he had a hydrocephalus at 2 months of age, and then he's underwent shunt insertion. Unfortunately, he got shunt infection on day 3 post-op, and it's very sad that he was sent home for palliative care with the oral antibiotics. The family was told that the boy would die before finishing of, given that oral antibiotics that got from the hospital. So 2 months later, after they left the hospital, grandmom saw that there's some skin erosions over the device, and it's got bigger over time. But they believed the doctors that they was told that the child will die. So they just kept the boy in the home for the next 10 months. It's total about a year after insertion. During that time, he got pus coming out from his open skin off and on. So I saw him in clinic, and I did a head measurement. It's at birth it was just only 31 centimeters, and then when I saw him, it's about it's below a third percentile. So this is the picture when I met him in clinic. So his shunt is almost come off, upper and lower, and you can see the pus discharge down here as well from both wounds. I managed to retrieve his first scan when he was 2 months old, and I'm really reluctant or hesitate to make a diagnosis. I hope that all the faculties and participants will help me give a diagnosis of this. Let me play it again. It seems like his brain squeezing in the middle, and some maybe hygroma or fluid just out.
No, I think it's hydranencephaly or partial hydranencephaly. Means actually the brain never developed except for that little part there.
But in the lower part, you can see that
you can see
all ventricle.
Yeah, you can see some. So these are the lower bits now, I think.
Yep.
So the diencephalon and posterior fossa are there, but the telecephalon and cephalon part of the brain's gone. That's why he can still survive. He can still, breathe and all that.
Right. So I think it's the same way. I think it's a hydranencephaly. At the lower cut, you can actually see that it's some ventricles there, but not the lateral ventricle. So what is your management at this stage? So I brought him. So I actually take him to CT. So this is the first CT in my hospital. This is the axial one. And this is the coronal one.
Instead of contrast enhancement, it could be a whole head full of pus already.
Pyocephalus.
Yeah, pyocephalus.
So at that stage, the first surgery, I did shunt removal, and I just put the EVD through the same hole that he's got, I can suck out lots of parts from it, and then I debride both wound and then do a primary closure. I give him so we got a culture. It's a Citrobacter cocceri. So I gave him a antibiotics IV for 6 weeks and intraventricular gentamicin for 4 weeks through the EVD. But it doesn't look improved at all. So I did a scan, the follow-up scan. I think both sides of the pockets communicate at the front, but the pus discharge keep coming out. Doesn't look good at all. So what is your management now?
Lavage.
Well, when I did that gentamicin injection, I did the lavage pretty much every day, but it doesn't make any difference. So
because you have how many days of lavage versus a whole year of infection.
Yes.
So I think it's enough at that stage. So I decided to do bilateral craniotomy and drainage and irrigation, and then I put another. I think I don't know whether it's subdurals or something, but he has a very thick subdural membrane, about centimeter or more, and then I put the subdural drain in there, and then give him another course of antibiotics. So I changed it to meropenem this time with a cefotaxime. That's a suggestion from our ID team, and then for another 6 weeks. This is the CT after the surgery. So I did a very good lavage, I think, and it was clear when I finished it. I left the drain there. So
so have you done lavage of the subdural space or the? So I thought the first shunt actually drained out the subdurals and the ventricles had enlarged and the pus was in the ventricles later on. But now from your description, I'm not too sure.
Yeah, I don't think that the first shunt was draining from the ventricle. Look at the scan. I think the shunt was put in the space that looked like a subdural space.
Okay.
Yes.
Yeah. So my next question is, after this, all the antibiotics 12 weeks, all the and intraventricular antibiotics for 4 weeks, and that cranial.
Your head circumference measurements, though, it's not accurate, because if you look at the picture, the head is turicephalic. It's long, it's towering, and so your head circumference measurements will not be accurate, because it doesn't reflect actually what's the brain or the skull volume. So, but it's growing, it's increasing. Good.
Yeah.
Did you get any organisms at any stage? Did you get any fungus?
No. For the second time, no. The culture wasn't show anything. There's no.
So what intraventricular antibiotics did you use?
Gentamicin for the first 4 weeks. Yep. And
okay,
so after all the treatment, my question and the head circumference like this. Were you designed to put a new shunt for him or just leave it?
What is the cell count in CSF?
Yeah, because the infection still doesn't seem to have settled. So I don't think.
I mean, unless I get a reasonable cell count in CSF, I am not going to put shunt at any stage.
Yeah, I think it the same way. So I decided not to put anything back in his head because I think his head is really microcephalic. So he is really okay now. He survived and just he's taking clonazepam for his spasticity. And you can see 2 years later, I did a repeat CT. And I think so now I'm going to call it subdural abscess. The pockets look improved and less enhancements and decrease in size. Yep.
So probably the infection stopped the hydrocephalus already or whatever. Because I think with hydrocephaly, one of the things that they say is you put a shunt, there's always a lot of failure. But if you do a CPC, actually the shunts usually work well without anything. And maybe in a way, this is not so much a CPC as to a infection and, kill up all the right plexuses and therefore the hydrocephalus becomes arrested.
Yeah, I think so. Like because when I went in, there's no you can't identify anything about but pocket and subdural membrane is really thick. That's all.
Doctor, can you just show which is the brain and which is the subdural membrane on the last scan?
The last scan, this one?
Yeah. Do we have a cortical mantle at all beyond that cavity?
So I don't know whether you can see so in the middle, I think in the middle is the brain. And then you have membrane wrapped around it like a horseshoe pocket. That is when I went in, that's a really, really thick membrane.
That is why you're calling it subdural abscess.
Yeah, I think it's subdural abscess, yes. I think what it is.
Yeah.
But I think the lesson we have to learn from this case is not so much this, but the fact that even when we think that a child has poor prognosis and we think that it should be palliative care, we should not just send patient home and say, don't come back. I think we still need to review, especially when you have a shunt. I mean, if you look at it, we should be also following our shunts up for as long as we can. Although, I mean, at my age, if I put a new shunt in, I probably won't see the kid for more than 10 years. But the point is, following up all these cases with shunts because they will get complications over time. And I think it's a very important thing. And the thing is, I think it's good that we have a whole group of pediatric neurosurgeons because I think every one of us cares about our patients. I mean, hate to say it, probably the person who did this was an adult neurosurgeon who just shunts when they want. And then after that, they just kind of ignore the fact that this kid can survive and things like that. Because I think, like in your country, the neurosurgeons say, don't come back. The parents are probably very scared to bring the patient back anyway. Right? But I think that's not the way we should be practicing, this type of, we shouldn't be doing this practice at all.
Yeah, I think that is a very good point. I think we just need to, even a palliative shunt, we just need to take responsible over the shunt and follow the patients up.
Yeah. Okay.
Would you consider a subgaleal shunt?
You mean in the first place?
Yeah, subdural subgaleal. Just to drain this infected material out.
If I have to drain the pus, I prefer to drain it out of the body rather than drain to subgaleal space.
Yeah, but you're not draining anything now. Now you're just not doing anything.
Yeah, and
That's
he's
correct.
been well. Yes, he's been well, and his head circumference hasn't grown anywhere. So I think it's now everything is a rest at this point. So I don't think that he will need any diversions or anything like that for now.
Okay, we have only 5 minutes left. So maybe I just show you a very quick case to echo Professor Xiao that for this 12 years boy with headache, poor appetite, DI, and obvious obstructive hydrocephalus like this. So what will you do, Professor Xiao?
Me, okay. I mean, obviously, this is a germ cell tumor because it's actually not just in the pineal and supracellular, but it's also affecting the periventricular area. I think in cases like this, obviously, are the ventricles big?
Yes.
because I can't see any except the third. But if the lateral, these are cases where you may be able to do a septostomy and put a shunt in for treatment of hydrocephalus. Obviously, you biopsy, and most likely this is a germinoma. The good thing about this is if it's a germinoma, actually with chemo and radiation, the thing just disappears.
Okay, so you will shunt?
Scan, is that the post-op scan at the back there, or I mean the second on the right?
Sorry, this is post treatment. Sorry.
Post treatment.
Yeah.
Yeah. See,
so
the
it's
tumor just
germinoma.
disappears.
Yeah, you are right. It's germinoma. But for the hydrocephalus, what will you do?
I think if there's hydrocephalus, because he can't do an ETV because the floor is tumor coated. So I would do a shunt. I mean, I know probably you might try to put it into the ventricle, but not so.
Yeah,
you
you
might block
can do
up.
a biopsy, do a septostomy, and be prepared for a shunt. If sometimes with chemotherapy, the tumors dissolve so quickly that you don't need to do a hydrocephalus shunt. Separate treatment for hydrocephalus occasionally.
Yeah. I just showed that currently with the warm lung ringer, you can still perform endoscope biopsy and over the supercellular and the pineal region in one session. And with the warm lung ringer, you can stop the bleeding in the endoscope surgery and do the ETV successfully and smoothly. And when you confirm it's germinoma, you just put the patient to the whole ventricle radiotherapy, and the patient will be like this. This is a post treatment, and the patient is shunt free. Yeah. Also, this is my showcase I want to share.
Yeah.
Okay.
I will put in an Omaya for this case. Robert?
Yes. I think it's a very many choice. I just show you that one of the possibility. Yes, I agree. Omaya is also a good choice.
Great.
Okay, Monfei, any further comment?
Right. I just to say that I won't do ETV for this case. You were brave, because the third ventricular floor seems to have a tumor there. So I will put in an Omaya and just do biopsy. Right.
Yeah, I agree. I wouldn't do the third ventriculostomy. And I would tell everybody, this is just exceptional. Only Robert can do. All of you, please don't do.
I have done a couple of times in germinomas, mainly because the oncologists say that with one shot of chemo, you will have the whole tumor destroyed and you can still probably get patency. So,
not true. Not always true.
Yeah.
But septostomy, endoscopic septostomy and shunt is also a good option.
Yes, it is. But after the treatment, the tumor was gone away, will you remove the shunt?
If there's no problems, I don't touch.
Yeah.
If the patient's asymptomatic, I don't touch. If the patients have problems with over drainage, then you consider, removing the shunt.
Okay. Yeah. There's always a discussion about this. Yeah. But because of time, now we are 5:30. But now is the end of the session. So Virginia, will you close the?
Yes. So I just want to thank everyone for your talks and presentation today, and for our participants. It was great to see you online. This is just to remind you that tomorrow's session starts an hour earlier than today. And so we look forward to seeing all of you there tomorrow.
Yeah. And Professor
Robert, let's go ahead and have a whiskey now, right?
That's right. Now's your whiskey chance.
Too early.
I'm so sorry for the Professor Guo that the time limit we are not be able to allow you to show your case. Sorry.
It's fine. Thank you. We need whiskey.
Oh yeah. That's
Yokohama.
the point.
Okay,
That's
Yokohama.
the point.
Yokohama.
Okay.
Please come to Yokohama and enjoy the whiskey.
Okay.
Absolutely.
Yeah.
Sure.
All right. See you guys tomorrow.
Thank you so much.
Yeah.
See you tomorrow.
Tomorrow.
See you tomorrow.
See you tomorrow.
Thank you, Dinesh. We'll see you tomorrow. If there are any queries, please mention in the chat.
Thank you very much.
Thanks, Professor Sakumoto.